Hello everyone, my name is Wartel and I'm the Deputy Director of the International Vaccine Institute Clinical Assessment Regulatory and Evaluation Unit at IVI's and also the Vaccinology Course Director. We are live in Seoul and it's my utmost pleasure to welcome you all to the 20th edition of IVI's International Vaccinology Course. I will be moderating today's session. IVI Vaccinology Course is one of the longest running courses of its kind in the Asia-Pacific region. It is typically an in-person program gathering professionals and fellows from around the world at IVI headquarters in Seoul, Korea for 5 days of lectures, breakout sessions, and networking opportunities with esteemed researchers, scientists, and health workers in the global health and vaccine fields. Since its founding in 2000, this course has aimed to promote vaccine sustainability in low and middle-income countries by training early to mid-career vaccine professionals and encouraging collaborative partnerships. We look forward to connecting with our colleagues every year and we're awarding fellowships to individuals who have made valuable contributions to public health in their home countries and may not have otherwise been able to attend the course in Korea. As you know, due to the ongoing COVID-19 pandemic, we are hosting this year's Vaccinology course, our 20th anniversary, online for the first time. This online format has its own merits. It is with immense pride that I share that we had more than 6,000 registrants from 155 countries, from Pakistan to Nigeria, for instance, or to Peru or to Portugal and beyond this year, representing a diverse range of professionals' backgrounds across academia, governments, nonprofits, international and private organizations. Meeting like this on Zoom has enabled us to register our largest class of trainees to date in a free and accessible platform, and for that I'm grateful. This year's course is made possible by generous donations from our course supporters and sponsors, JSK, Johnson & Johnson Janssen Vaccines, National Vaccine Institute of Thailand, RAFAS, and SK Bioscience. With IVI's mission to discover, develop, and deliver safe and effective and affordable vaccines for global public health, a central tenet of our work and how we work is building capacity, especially in low and middle-income countries, which includes providing technical assistance in vaccine manufacturing, tech transfer, and performing on-site trainings and educational courses such as this one. As such, the Vaccinology course emphasizes practicality, covering the vaccine development spectrum with applied topics across different topics, discovery, development, and delivery. This year, the course additionally, of course, will pay particular attention to COVID-19, including immunology, preclinical studies, and COVID-19 vaccine development, and the role of international community in responding to a virus that knows no borders. Of course, the COVID-19 pandemic is far from over, and indeed some of our upcoming lectures will touch upon, if ever, we will truly recover from its consequences, and IVI extends its support to our partners and colleagues around the world who continue to be directly impacted. Over the course of this week, we'll also cover topics such as maternal immunization, the role of vaccines in reducing antimicrobial resistance, and vaccine communication, just to name a few. With a distinguished lineup of experts leading their fields and playing crucial roles in drawing the end of COVID-19 pandemic in sight. Before we get started, I'd like to share a few housekeeping notes. Our live sessions will begin at this time every day this week, and a recording of each day will be made available on IVI's YouTube channel on the same day at 3 p.m. Eastern Time. These recordings will only be accessible during this week. Most of our lectures will be followed by a live Q&A, with some speakers given the time zone. Please submit your questions in the Zoom Q&A and kindly understand that we may not be able to address all your questions live. Course observers will review and refer your questions to the lecturers as time permits. For this first session, we will have 3 speakers, Dr. Derrick Sim, Dr. Jakob Cramer, Dr. Jung OBrien, and also we have Mr. Prasad joining us. Actually, we have 4 speakers who can join for the live session. Short polls will be sent to you at the end of every session, and these polls are anonymous, and your feedback on the lecturers and the speakers will be very much appreciated as we develop further courses. For those who are joining us live on Zoom, a digital certificate will be made available upon request. We will note your Zoom login details, and an attendance rate of 90% throughout the week will qualify you for a certificate. Once again, welcome to the 20th anniversary of IVI's International Vaccinology course. Now, without further ado, it's my honor to present pre-recorded congratulatory remarks from Madam Jung-sook Kim, First Lady of the Republic of Korea and Honorary President of IVI Support Committee.
안녕하세요. 반갑습니다. IVI 한국 후원회 명예회장을 맡고 있는 대한민국 대통령 부인 김정숙입니다. 제20차 IVI 국제 백신학 연수 과정을 진심으로 축하드립니다. 제롬 김 IVI 사무총장님, 교수진으로 참여하는 WHO, GAVI, CEPI 등 국제기구와 각국 정부기관, 백신 학계 및 업계 관계자 여러분, 연수 과정에 참여하고 계신 전 세계 백신 및 보건의료 전문가 여러분, 뜻깊은 개회식에 함께하게 돼 반갑습니다. 대한민국은 세계 유일의 백신 개발 국제기구인 IVI 유치국으로서 지난 24년간 인도주의적 백신 개발과 공평한 보급에 매진해온 IVI의 노력을 전폭 지원해왔습니다. 36개 국가와 WHO가 참여 중인 IVI에 가입 의향을 밝히는 국가들이 늘어나고 있습니다. 모든 인류가 전염병으로부터 안전한 세상이라는 IVI의 비전 실현을 위해 매우 고무적인 일입니다. 지난 2000년에 출범해 아태 지역에서 가장 오래 운영되어 온 IVI 국제 백신학 연수 과정은 전 세계 1,500여 명의 전문가들에게 백신학에 대한 필수적인 전문 연수를 제공함으로써 각국의 백신 및 예방접종 역량 강화에 기여해 왔습니다. 그간의 노고와 성과에 지지와 격려를 보냅니다. 팬데믹 상황에서 백신의 중요성이 그 어느 때보다 부각되고 있는 가운데 올해 5일간 진행될 연수 과정에는 코로나19와 힘겹게 맞서 싸우면서도 어렵게 시간을 낸 150여 개국 6천여 명의 백신 및 보건의료 전문인들이 비대면으로 참여하고 있습니다. 의료 현장에서, 실험실에서 인류의 건강과 안전을 지키기 위해 혼신의 노력을 기울이고 계신 여러분들에게 경의를 표합니다. 유례 없이 빠른 속도로 개발된 백신 덕분에 국제사회는 코로나 종식이라는 희망을 갖게 되었지만 백신은 모든 나라, 모든 사람에게 공평하게 보급되지 않고 있습니다. 심각한 글로벌 백신 공급 부족과 변이 바이러스 확산으로 팬데믹이 지속되고 있는 지구촌에서 모두가 안전하기 전까지는 누구도 안전하지 않습니다. 다양한 백신의 개발과 충분한 공급이 무엇보다 시급합니다. 질병과 감염의 공포라는 고통을 수없이 극복해온 인류의 역사에는 의과학자들의 집념과 헌신적인 인류애가 있었습니다. IVI 국제 백신 연수 과정에 함께하신 전문가 여러분의 역량과 지혜를 한데 모아 보다 안전하고 효과적인 백신의 개발과 공평하고 충분한 보급을 실현하는 길이 더욱 가까워지기를 기대합니다. 저는 IVI 한국 후원회 명예회장으로서 국경 없는 백신으로 건강한 지구 공동체를 만들기 위한 국제적 연대와 협력 강화를 위해 최선을 다하겠습니다. 제20차 IVI 국제 백신학 연수 과정을 거듭 축하드리며 모든 참가자 여러분의 건강을 기원합니다. 감사합니다.
Thank you, Madam Kim Jung-sook. Please now welcome our Director General, Dr. Jerome Kim, for the keynote remarks, including the global COVID-19 situation update.
Good day. It's my honor and privilege to open the 20th annual Vaccinology course, our first ever virtual course, with a brief introduction to vaccines, vaccinology, now COVID-19, and IVI itself. This is the IVI vision and mission. The vision and mission have remained unchanged since our inception 24 years ago. Developing countries free from suffering from infectious diseases, and our mission to discover, develop, and deliver safe, effective, and affordable vaccines for global health. IVI is a 3-in-1 organization. We're a bit of a research institute where vaccines start in the laboratory and then progress their way through product development, our second component, towards eventual licensure, creation of stockpiles, and implementation worldwide. We finally are an international organization, the only international organization, as you heard First Lady describe, that is dedicated to the development of vaccines for global health. IVI is a global research institute, 36 member countries in WHO as state parties, an initiative of the United Nations Development Program, a place where 184 people from 23 different countries work every day, supported and working with thousands of collaborators around the world. We currently work in over 28 countries worldwide, in Latin America, Africa, South Asia, and Southeast Asia. Moving now into the vaccines. There are 26 vaccine-preventable infectious diseases. They're listed here on the slide. I've added SARS-CoV-2 since there are now vaccines emergency use listed and also approved for SARS-CoV-2. But the things that vaccines do is really what concerns us today. We know that vaccines can eliminate deadly infectious diseases. The last case of variola minor in Somalia in 1977, the last case of variola major, that is smallpox, in Bangladesh in 1975, smallpox was declared wiped out by the World Health Organization in 1980. Next, hopefully, at some point in the near future, will be polio. And once COVID is behind us, let's put every effort we can into eliminating yet another deadly infectious disease. We also know that vaccines prevent cancer. If we look at those diseases, infectious diseases associated with cancer, hepatitis B causing hepatocellular cancer, and human papillomavirus causing cervical cancer, vaccines against these viruses by themselves will significantly impact hepatocellular cancers in Asia and Africa, and also cervical cancer. And there's already a proof of concept. Cervical cancer has nearly been eradicated from Australia as a result of effective programs of HPV vaccination. We know that vaccines can prevent cancer. In addition, vaccines are cost effective. There are very few things that a government can do that has a better return on investment than a dollar spent on vaccines. A single dollar spent on vaccines saves $16 in future health care costs, lost income, and lost productivity. If you include all the things that vaccines do, the return on investment is $44 for every dollar a country invests. Very few investments equal the benefit of vaccination. We also know, these are data from the US CDC for a 20-year period, 1994 to 2013, that in the US, vaccines prevented 322 million illnesses, prevented 21 million hospitalizations, and 732,000 deaths. That's $295 billion in direct costs, $1.4 trillion in total societal benefit. Vaccines are cost-effective. But in addition to impacting disease and death, vaccines have additional societal benefits. We know that effective vaccination programs improve the level of attainment in education and improve cognitive development in children who are vaccinated. Herd immunity has profound effects for populations around the world, as vaccinating children also protects adults who happen to live, work, and play with those children. Vaccines have a direct and indirect effect in the prevention of antimicrobial resistance. You'll hear about this very exciting work later on in this vaccinology course. It also improves health and economic prospects. It increases gross domestic product, so it has a direct, or I guess an indirect effect on economic growth. And according to GAVI, vaccinations improve IQ, are associated with higher survival and a lower birth rate, are associated with higher parental productivity, and are responsible for 30 to 50% of the giant spurt in growth that Asian countries had in the 1990s. Vaccines have enormous benefits not only on disease and death, but on society as a whole. Let's think about vaccines and antimicrobial resistance, a major topic during this year's vaccinology course. WHO has already prioritized a list of pathogens, that is bacteria, that are associated with significant degrees of antimicrobial resistance and for which the development of vaccines might provide substantial benefit. We already know that by 2050, drug-resistant infections could kill as many as 10 million people a year and cost $4 trillion. We also know that better use of existing vaccines against H-flu, Streptococcus pneumoniae, and Salmonella typhi are associated with decreases in antimicrobial resistance. We know that better antimicrobial stewardship and new antibiotics are a part of the solution, but vaccines against AMR priority pathogens could have a profound effect on our ability to prevent what we anticipate in 2050, 10 million deaths a year from antimicrobial resistant bacteria. In summary, in 200 years, vaccines have critically changed human morbidity and mortality and have the potential to do more. We know that vaccines work to prevent morbidity, mortality, cancer, and have numerous additional societal benefits. We understand that vaccines are cost-effective, but that they only work when used. As you'll see later, it's vaccination and not vaccines that save lives. So we need to keep developing new vaccines. And there are still diseases with high burden. Development of vaccines is a lengthy and expensive process and very risky. Therefore, we need new mechanisms for funding vaccine development. Switching quickly into COVID. This is the global COVID burden from the end of 2019 to present. As of September 1st, over 200 million infections, over 4.5 million deaths. You can see the number of new cases per day shown here. You can really see the pronounced waves of infection that have swept through the world, through all populations, killing 4.5 million people. We also know that it takes a while to develop vaccines. So you can see when the pathogens were discovered and when the vaccines were introduced. Sometimes this can be decades. We didn't have decades with regard to COVID-19, and we were able to convert a process which is 5 to 10 years and $500 million to $1.5 billion into a process that was accomplished in 10 to 11 months. This was done by taking the normal phases of vaccine development, phase 1, followed by phase 2, followed by phase 3, followed by, if the vaccine is safe and efficacious, by registration, with a process that was telescoped, where phase 2 began shortly after the beginning of phase 1, with the generation of adequate amounts of safety and some immunogenicity data, where phase 2 generated immunogenicity and safety data after the final dose, and phase 3 started shortly thereafter. This allowed us to telescope development, to shorten a development time of 5 to 10 years into one of 10 to 12 months. A really remarkable achievement. It's really kind of easy to say now, in retrospect, that proving that vaccines could be developed in 10 to 12 months to be safe and to be efficacious was relatively easy. The bigger task has been shown to be making enough vaccine for the 8 billion people in this world and using that vaccine with some sense of equity and justice for everyone on the planet who needs it. We've taken a process that normally takes decades. That process is the dissemination of innovative technology in vaccine development. You know, I used rotavirus vaccine as an example. Rotavirus vaccine was approved by the US FDA in 2006. It was approved by WHO and recommended in 2009. In 2021, 60% of the world's children still do not receive 3 doses of rotavirus vaccine. We knew we didn't have that kind of time with COVID. So GAVI, CEPI, and the World Health Organization got together and created COVAX. 190 countries banded together with the promise of having 2 billion doses of WHO pre-qualified vaccines available by the end of 2021. We've secured commitments for 5 billion doses, which would account for roughly 20 to 30% of countries' anticipated need, enough to vaccinate easily the elderly and healthcare workers. This could be a bridge to near concurrent access to innovative vaccine technology and would be a wonderful thing if we could continue this, if it could be successful. We're worried. So far, according to UNICEF, only 236 million doses have been distributed to 139 countries. We have till the end of the year to get to 2 billion doses. 85% of vaccine doses have been used in high and upper middle income countries. 60% of the world's population has not received a single dose of COVID-19 vaccines. There will be consequences of the failure of access and equity. 3 big ones. First, the humanitarian crisis. Modeling in 2020 suggested that if we failed to distribute the first 2 billion doses of COVID vaccines with some sort of equity, global COVID deaths would double. Global COVID deaths at that time were about 1.5 million people. We're already at 4.5 million people. This is something that is upon us. The second is an economic crisis. Without equity, 3 different organizations, National Board of Economic Review, the Brookings Institute, and the US CIA, said that if we failed to distribute vaccines with equity, that there would be global costs to high-income countries as well as low and middle-income countries. That global cost, $4 to $5 trillion. We're in the middle of 2021. We appear to have fallen short of the goal of distributing 2 billion vaccines to countries around the world. I hope that the economic crisis will not be as profound as was predicted. The final consequence is a biological one. We know that the mutant viruses that threaten the efficacy of the vaccines we have currently available are generated in uncontrolled outbreaks. Around the world, there are outbreaks that are not fully characterized, generating mutants that are not yet sequenced. Do these mutants have the capacity to undermine the successful development of vaccines over the previous year? Yes, they do. The only piece of good news is that the current vaccines work against the current viruses. For that, we can be thankful. But we need to move quickly and prioritize vaccine shipments to countries around the world and help them to characterize the size and extent of the outbreaks and the generation of new mutants. This gives us an example of where COVAX should be in orange versus where they are in purple from January through June in terms of deliveries, and where they anticipated they would be in light blue from July to December. So note that we've distributed 236 million doses of vaccine by the beginning of September. We should have been at 500 million doses. Let's not fall behind. COVAX is too important to fail. This is a mechanism that, if successful, would be a new way to bring vaccine technology to people around the world. There are many reasons. COVAX is a complicated organization. Distributing 16 billion doses of vaccine was never going to be an easy task. And there are slowdowns everywhere, from approvals to manufacturing to contracting and deliveries. There are failures of, there's a lack of ability to distribute vaccine. We do a reasonable job vaccinating the 130 million children in the birth cohort. 80 to 85% of them get the EPI vaccines. How are we going to distribute 16 billion doses of vaccine around the world using the infrastructure that we have currently? We need to find funding. Oops. How much is needed? 50 to 70 billion. What is the return on investment? According to the IMF, $9 trillion if we do this right by 2025. Our global scorecard you've seen already, we've distributed 5.5 billion doses. 1.8%, only 1.8% have gone to low-income countries. 40% of people around the world have received at least 1 dose, which means 60% of people around the world have received nothing. There are still other big questions for COVID-19 vaccines. Optimization of dose, scheduling. Do we need boosts? Can we do mix and matching of boosts? Do we understand the correlates of protection? Do we need to have a better understanding of effectiveness? Do we really know when herd immunity will be obtained? What kind of surveillance are we doing for mutations, or what is the extent of the outbreaks in developing countries? Again, big questions for which we have incomplete answers at best. We really need to have longer-term safety follow-up and post-licensure safety monitoring in countries around the world. And finally, opposition to vaccination is something, and we've seen it already, that is impairing the success of vaccination programs even in countries with relatively high levels of vaccination. We need to convince everyone to be vaccinated. So there is a future of challenges. Supply, implementation. Where are the outbreaks and what variants are being generated? Finally, who is going to lead the effort against COVID-19? Is this going to be an effort without a leader, without someone who will be accountable for the distribution and effective vaccination of 8 billion people around the world? Who is that? And who has the responsibility to lead? We work with a lot of partners at IVI, developing vaccines across the value chain, and we're proud of it. We would hope to be able to do more. And I hope that with the benefit of this course, some of the 6,000 people who've signed up will be able to contribute to developing the next generation of successful COVID vaccines, or getting those vaccines into the arms of people who need them. Thank you.
Thank you, Dr. Jerome Kim. So let's move on the day one theme related to the role of international organizations in the COVID-19 pandemic response. So let me welcome Dr. Sylvie Bryan from WHO to give us an update on the SARS-CoV-2 variants of concern.
So, good morning. I'm Dr. Sylvie Bryan from WHO in Geneva. I'm the director of the Global Infectious Hazard Preparedness Department. This department is in charge of emerging diseases and preparedness for pandemic. And so it includes, among many other pathogens, COVID-19, of course, influenza, plague, smallpox, monkeypox, arboviruses, Zika, chikungunya, and so on. So the role of this department is to provide technical expertise about pandemics, response, and preparedness. So my talk today will be on COVID-19 and in particular SARS-CoV-2 variants of concerns and what do we know as of today. So first, I will just summarize a little bit where we are with this pandemic of COVID-19. And as you see on this slide, we are still in a pandemic and we still have quite a high number of cases that are reported to the World Health Organization. In August, for instance, as of 9 August, in the previous week, we had more than 4.2 million new cases reported and more than 65,000 deaths reported as well from different countries in the world. So on this slide, what is interesting to see is that first you have different regions affected at different time, and the colors are for the different WHO regions. And so this pandemic has a very unique dynamic. It started in Asia, in China in particular, but then spread to the entire world. But each continent has had its own dynamic. Some of it is probably a link to the seasonal patterns, but other dynamics are more linked to human mobility and also the density in large cities. So the other thing we can see on this slide is that at the beginning of this pandemic, the death, and you see it's a dark curve, the deaths were very high compared to the case reported. And because in many countries the testing was not adequate and sufficient, so we could monitor the spread of the virus more through the death rather than through the cases. But now this situation has changed in most of the countries, and the testing capacities has increased a lot. So now we have a better reporting of cases, and therefore we can better also calculate the case fatality ratio and understand better the impact of the virus on health. So far, we have had more than 200 million cases and more than 4 million deaths. And this will continue, unfortunately, for some time, because even if we have more tools, such as the vaccine, the virus is also evolving and continue to spread. And so we anticipate that we'll have to fight this pandemic for a few more months. So here, just to show you what I alluded to before, is that the dynamic was very different in different continents. And here you see, please look at the number of cases on the vertical axis. You see that the scale is very different. In the Eastern Mediterranean, we are talking about, in America, we are talking about 100,000, while for example, in Western Pacific, you see that the scale is much lower and it's 20,000 instead of 100,000. So it's very important. So the number of cases varies a lot depending on the continent, and also similarly, the number of deaths as well, because the number of deaths really depends on the health system and how the health system can cope with rapid increase of cases. Some health systems are already very weak, so having an outbreak on top of it, of course, makes things even worse. And this is why in some countries, even if they don't have a huge number of cases, they still have quite a high mortality because their health system has difficulty to cope with this additional burden. We will talk about it later, of course. What is very interesting to see is that in Europe and the Americas, they have had a huge number of cases, but the number of deaths has remained quite low compared to the number of cases, while, of course, in certain countries, it's the contrary. And when you look also at Southeast Asia, you see that there is this disconnect between cases and deaths, which shows that probably a number of cases are not detected or reported. And what we see is only the impact on mortality at a later stage. So, of course, since a few months now, we have seen the emergence of variants. So it was not unexpected. We know that viruses evolve. And so this one is doing the same as other viruses. What is interesting is to see that because of human mobility and because also of the specific dynamic of epidemics in different countries, the spread of variants have been slightly different. And but also what is interesting to see is that in many countries, the variants are co-circulating. And so it's a dynamic situation. What I will show you today is what we have currently, but maybe in 3 months from now, it will be completely different. And it's very hard to predict how it will evolve because of this very dynamic situation. And the fact also that vaccination has started in some countries, and so it may also change slightly the evolution of variants and also the way they will spread. So currently we have 4 variants of concern: Alpha, Beta, Gamma, and Delta. And here you see when we started to discover them. So WHO has done 2 things that are really important. First, we have named the variant against the Greek alphabet because initially it was numbers like B117, B1617, etc. So it was a bit hard to communicate about those variants. So that's why we chose this nomenclature. And secondly, we have also defined among all the variants that are existing, what are the ones of concern? I mean, the one that we fear that they have impact on transmissibility, on virulence, or may put at stake the current measures and interventions we have in hand. And so that's why we have 2 categories of variants: the variant of concern and the variant of interest. Regarding the variant of concern that you see on these slides, for Alpha, it started in United Kingdom and it was detected first in December 2020. The Beta was nearly detected at the same time later, but probably was predominant, similar at the same time. And then we had the Gamma in Brazil, and then the Delta in India. So we also abandoned the denomination by Indian variant, Brazilian variant, and so on, because this increased stigma on population and had also a huge impact on travel and visa for travelers. So for those reasons, we moved to this nomenclature based on the Greek alphabet. So we have also some variant of interest, eta, iota, kappa, and lambda. And so these are interesting variants. We are monitoring them, but probably their impact on public health is much less, or they are very localized, not yet spread, and maybe they will never spread. So that's why we currently monitor them, but we are paying less attention to them than for the VOCs. So for the VOC, what is important is that really to assess what is their impact on transmissibility, disease severity, the risk of reinfection, and the impact on diagnostics, because this has significant consequences on the way we will respond to the pandemic. So, and you see here in this table that most of them have increased transmissibility, and this is well explained by the fact that they are probably more fit to a human body. As the first emergence of coronavirus, it was a zoonotic virus, so probably less able to infect human. But as we move forward, the virus is adapting to the human bodies and receptors, and that's why there is an increased transmissibility. Regarding disease severity, we don't see much difference. So the virus is probably not more virulent, but we have increased risk of hospitalization, because if you have more cases, you have more risk of having, or more proportion of severe cases. But we see that these variants are behaving same as the initial variant. Basically, we have 80% of mild disease and 20% of severe disease. So, but if we have more cases, of course, we will have also more severe cases in absolute number, even if the proportion remains 20%. And of course, as I said earlier, mortality is very dependent on the capacity of the health system to cope. And so when health systems are coping with more cases, then of course they have less capacity to reduce mortality. And this is why also we have seen more mortality with certain variants in certain settings. But it's probably not due to the virus itself, but more due to the health system capacity to cope with this situation. And regarding reinfection, there have been observation of reduction in neutralizing activity, but this is still something we need to investigate and monitor, because conclusions are not easy to make, and because there are a lot of things that are linked to the context of the spread of the virus as well that may influence those kind of things. And finally, regarding impact on diagnostics, we are still on the same side, and diagnostics are still useful and are still efficient. Sorry. So what also it's really interesting to see is the dynamic of those variants. And you see in some countries that the Delta variant, for instance, has replaced the other variant. So the Delta is the yellow one. So in the US, for instance, in Israel and in UK, where it's also very important because to monitor in those countries, because these are countries with nearly full population coverage with vaccination. So it's very interesting to understand the dynamic between vaccination and variant, and that's why some countries are really important to monitor. In India as well, the Delta variant has spread widely, although we have already observed some sublineages, so we need also to monitor this more carefully. In other countries, you can still see other variants. For example, the Gamma variant in Brazil is still predominant, but we will see if in the near future it will change. So this is just to remind you what are the drivers of the emergence of variants for SARS-CoV-2. You have a natural selective pressure from antibodies. So when the population is immunized against a certain variant, then you may see the emergence of new variants because they want to escape the immunity of the population. you may have also a drivers, which is a founder effect. And I think this is what we have seen, for instance, in India, because in India, when the Delta variant emerged, they had a major mass gathering for religious purposes, with people coming from different parts of the country and gathering all at the same place. And it was very dense. And so it provided to the virus an opportunity to circulate much faster, and probably an opportunity also to make sure that if a variant that is fit for purpose emerge, it can also very quickly infect millions of people at once. And so that's why we saw probably the emergence of Delta at that time. And so, of course, it's very hard to disentangle one drivers from the other, and probably many mechanisms at play in the same setting at a given time. There are other mechanisms for emergence, for example, species jumping, and I will talk about it a bit later. And you have also a persistent infection in immunocompromised host, where they host many different variants at the same time, and you can have a possibility of competition among variants. And at the end, maybe a more transmissible one or virulent one can emerge. So that's why it's important to monitor what is happening in hospitals where you have those immunocompromised people hospitalized, and making sure that they don't start a new outbreak with a new variant in these settings. And then you have some mutations that are more risky than others. The ones in particular affecting the proofreading function. And this is why we have a special group of experts on monitoring the virus evolution and trying to anticipate which mutation are more likely to produce a bad impact for public health. And so we are still learning because it's a new disease, but I think this is a very important part of the science nowadays, is to forecast what mutation can be more impactful on human communities. So, as I said, one of particular driver of emergence is jumping the species barriers. And we had an experience in Denmark last year with the mink. The mink population was infected by human, and then the mink themselves infected human. And so with this transmission between species, you see that variant evolve very quickly, the virus evolved very quickly. And so that's why in Denmark, they had to kill 17 million of mink to reduce the risk for humans to have emergence of a more virulent and transmissible variant. Here you see on this slide the situation with influenza viruses, and I'm making the parallel because for influenza viruses, we have different subtypes circulating at different time, and the proportion of each subtype varies depending on the continent or the transmission zone of influenza. And this parallel is interesting because it shows that first, this is why we need to monitor different type of viruses throughout the year, because we will have a different picture throughout the year. And the second thing that you see here is that we have very few influenza viruses, and we don't know if it's because COVID-19 is dominating, and so influenza viruses are circulating less, or if it's because also the laboratories are so busy with COVID-19 that they don't have time to fully explore influenza during this pandemic. So, but nevertheless, the parallel is there for you to understand that we'll continue to monitor SARS-CoV-2 variant because it may have an impact in the future on the composition of the vaccine, as it has for flu vaccine. And as you may know, we define the composition of the flu vaccine once a year. So for COVID-19, we don't know if we will need to do this, but and we don't know the frequency. It might be every 5 years, every 10 years. We don't know yet, but still it's important to put in place mechanism to see if we need to update the vaccine, and if so, what kind of vaccine we would need in the future. So variants are expected, and we know, but that's why we are monitoring them, but not every variant will be of concern. So that's why we need to have mechanism in place to identify and assess those variants and communicate accordingly, because it has an impact on public health policy. We need to evaluate the impact of the variant on public health and social measures like mass gathering, mask, washing hands, and so on, school closure, but also the impact on vaccination program and other medical countermeasures and health system. And that's why, because it's a pandemic, we need a globally coordinated response. Because if one country does something, but the other country do something differently, it will be very difficult to understand what is due to a specific context and specific response measures compared to what is due to the virus itself. So it's really important to be coordinated in terms of assessment, evidence gathering, and response. And that's why we also need an integrated framework that can identify what decisions must be made and what data will support this decision making. Among the questions we are asking ourselves because of the variant are, is the variant more virulent, more transmissible? Do we need to adapt public health and social measures? Do we need to change vaccination policy or adapt vaccine composition? Do we need to change therapeutics, for example, monoclonal antibodies? Or do we need to adapt protocols, therapeutic protocols? Do we need to change or adapt the testing strategy, and which tests should be used to better achieve this goal? What is the impact on health systems? Do we need to define new infection prevention and control procedures? What can be done to mitigate the impact on health system and reduce, for instance, the number of cases that are arriving at the hospital? What are the implications for equity, especially global equity and access to those tools and intervention? And what kind of research is needed for the future? So we have done two things. First, developing a risk monitoring assessment framework, which highlight the various elements that we need to consider for decision making. And we are also developing guidance for data collection, sharing, analysis. And so this is in the making. But we are also working on coordination mechanism because, as I said earlier, it's a pandemic. It's not something that can be done only in one country. We need to be coordinated globally. And this is where WHO is working. And we use our convening power with our 194 member states to make this happen. So many components are already existing, but some are being developed because it's a new disease. And so we need also to look at this as a longer term coordination and framework because, as I said, probably this virus will stay with us for longer than expected. And so we cannot just do things for the next month. We have to think about the next year and probably the next 10 years. And so this is the time frame we are looking at currently. So here I will just highlight what is our approach at WHO. We know that we need to monitor and have a good surveillance of those variants. We need also to, once we have the evidence, we need to assess the evidence. So produce the evidence, but also assess it in a coordinated way. And at the end, we have the policy decision making that happens once we have assessed this evidence. So we have already the SAGE, which is the group at WHO that decide on vaccine policy. So this group was existing before the COVID-19 pandemic and is working on COVID-19, of course. But we don't have groups to monitor the variant and decide if a variant is of concern or of interest. So we are creating this group and it will be called TAG VE. And we have also created a group called TAG COVAX to review the evidence, assess the evidence on vaccine effectiveness, and also decide if we need to change the vaccine composition. So I will go through this process and highlight for you what are the challenges. So on the monitoring and evaluation and surveillance of the variant, the first problem we have is that you need to have sequencing capacity, genomic sequencing capacity. And unfortunately, this genomic sequencing capacity is not evenly distributed. And so there are many countries with little or no capacity. And so we need rapidly to strengthen this capacity to make sure that those countries can contribute to a global surveillance system. Secondly, we don't know yet how much testing is enough. And so because it's a new disease with, as I said, a very strange and different dynamic around the world, we know that we cannot test all the cases, but how many of them should be testing to understand what is the distribution of variants, what are the dominant variants, and also detect if we have new variants. So we are testing different ways, and one of the way we are looking at is really what we do for flu, because for influenza we do have sentinel systems, and so we are seeing if only using the same sentinel site and having a proportion of testing in those sentinel sites provides the same results as if we test cases with different strategies. And it seems that using sentinel sites and testing in those sentinel sites will provide a very good data and sufficient at least to make a good decision about the variant. So this is work in progress, and we are also developing guidance to help countries to decide how they want to test the variants and genomic sequencing. So the impact of variant on vaccine, for instance, is very complicated because we have different type of vaccines, so different type of impact. Now, some countries are using mix and match, meaning they use a certain platform for vaccine, for example, mRNA vaccine, and then they use a virus vector vaccine. So very hard to know if the person is not protected, if it's due to the vaccine or due to the variant. And again, the evolving epidemiology makes our job very complicated. And global coordination is not only needed, but it's really critical at this stage, and not very easy because everybody is struggling with the disease in its own country. So we are developing this framework to review the evidence on vaccine and seeing if we need, how we can assess existing vaccine, but also the new vaccine in the pipeline, because many manufacturers are now producing different types of vaccine based on different platforms. And so we need to really assess this as well. As well, we have some people talking about boosters. So for all those reasons, we need this framework. So we have developed those expert groups, but also we are developing standardized study protocol and assays to be able to have this coordinated assessment of the vaccine effectiveness. We are promoting rapid data sharing, not at the pace of the research, but really just having something that is very real-time data sharing so that we can make more assessment in real time as well. And we have developed also a repository for global evidence on variants. It's on our website, and so you can have a look at it. The data needs are many. We need stronger epidemiological and genomic surveillance, especially for low and middle income countries. And we need information on breakthrough infection. We need also disaggregated data by level of transmission, if it's in a cluster or if it's a community transmission, geographic prevalence, population level of immunity, the type of vaccine, the type of manufacturer. If you have different manufacturer producing same vaccine using same platform, for example, data for Pfizer, BioNTech, and data for Moderna, we may have differences. So that's why we need those data. And also the number of doses administered, if it's first dose, second dose, and maybe in the future, third dose. So that's why we need those data. We need also a better understanding of protective immunity and threshold for correlates of protection, which we don't have yet fully adopted. And we need also to use standard protocol for studies and standard assays as well, which is not the case. So currently we have very different results for vaccine effectiveness, but sometimes it's due to the assays that is used. So we need also to standardize this. So for the evidence assessment currently, as far as we know, and our expert group have said that the vaccine available and in development offer acceptable level of protection against current VOC. So we don't need to change the vaccines, and we don't need to change their composition. Of course, we have reservation because of the interpretation due to data gaps and quality and bias in observational studies, but so far so good. And so that's why we want to reassure the public on that. There are many vaccines in the pipeline, and so we need really to understand if those vaccines are as effective as the current ones. And that's why we are undertaking immunobridging discussions in the context of variants and see what kind of guarantees and data regulatory agencies will ask in the future for those new vaccines. We have had also many discussions on booster. And so we don't like very much to call it booster. It's rather a supplemental vaccination for people who have not responded well to the third dose. But the discussion is ongoing, and we have the consultation last week, for instance, on this. Are they needed? Will it increase protection? And what is the goal of vaccination? Do we want to protect against severe disease or protect against transmission? When do we need to use? What kind of vaccine? Who do we need to vaccinate? So there are still many questions on the table, and we are looking at many elements for decision. The duration of protective immunity, which is still not known, the objective of the vaccination, of course, the type of vaccine, the efficacy and effectiveness, etc. And finally, a very important element to consider is really the global situation. As you know, as when I am speaking currently, in many low-income countries, they have not been able to vaccinate their population. They have had access globally to less than 1% of the vaccines that are available. So we are really, really below the threshold of vaccinating a high-risk population in those countries. So the problem is that if some countries are using a third dose or are starting to vaccinate their entire population, then there is no vaccine for those countries. And therefore, we cannot control rapidly this pandemic. And we also may face more risk to have new variants emerging of different kind in those countries where they are not vaccinated. So this is just to show you how many consultations we have done since December 2020 on this subject of variants and trying to assess what is the situation. There are more. And just to tell you that you can find them also, the reports on our website, and if you are interested on specific disease. I will finish with just highlighting this issue of vaccination strategies, because I think in the media, it's very confusing. And and I think it's very hard for people to understand what we are currently doing. So that's why it's important to clarify when you talk about vaccine, what is the strategy? What do you want to achieve with the vaccination? The first could be, for example, to reduce severe disease and death. And this is what the vaccination strategy WHO promoted a few months ago, because we didn't have enough vaccine. And we said, okay, let's at least vaccinate people so that we can reduce severe disease and hospitalization and the death. And so really, we wanted to impact on mortality, but also hospital coping capacities, having a better care for other pathologies, and reduce, of course, public health and social measures, because many countries said, okay, because our hospital cannot cope, let's flatten the curve, so let's lock down. And so there will be less transmission, so we can protect our health system. So if the health system is protected because people are vaccinated, then you can also reduce, you don't need knockdowns anymore, because you can reduce transmission just by having normal, for example, personal measures. So when we look at this objective, we wanted to target 20% of the population globally, which correspond to elderly and at-risk group plus healthcare workers. So, and this was the first 20% that was in the media, because for us it was a global goal to achieve this objective. Of course, in certain countries, it could be 30%, 40%, depend on number of comorbidities and high-risk groups you have in such countries. Then if you want to protect health workforce, globally, the health workforce is 3% of the population. It includes, of course, doctors, nurses, but also all the people working in the health system. But those people were particularly at risk at the beginning of the pandemic, and in December 2020 we did a studies, and health workers still represented 7% of the total cases. So it's an important high-risk group. And here, of course, the objective is to reduce nosocomial transmission, reduce absenteeism due to health worker having COVID-19, and also reduce mortality in health workforce. You have seen recently major epidemics due to COVID-19 in Indonesia, for instance, and many health workers lost lives during those epidemics. So this is very bad because not only it reduced the capacity of the country to deal with the current epidemic, but also it weakened the health system for the future and offer opportunities for other diseases to spread and to affect the population. So SARS-CoV-2 variant will continue to evolve. SARS-CoV-2 virus will continue to evolve and variant to emerge. So that's why we need ongoing monitoring. The Delta variant is more transmissible, but public health strategies are still effective and to keep the pandemic under control. And current vaccines are still effective at protecting against severe disease and hospitalization. As it is a new disease, many assessment processes will need to be created to fill the data gap and strengthen evidence-based decision-making. And for the global context, it's very important to take this into account because during a pandemic situation, national or regional decision on vaccination can increase the inequity in access to medical countermeasures and delay the global recovery. And I thank you very much for your attention.
Thank you, Dr. Bryan, for this very comprehensive presentation. 2 points before we move on. The first one is related to a technical issue. We have been told that there is a quality issue, so please bear with us. We are fixing the resolution for the upcoming presentation. We are doing our best with the IT and technical team in IVI to improve that. All the presentations will be shared. That's another announcement I wanted to do. I didn't mention that at the beginning. So let's move on with and welcome Dr. Derrick Sim from GAVI to talk about the global supply of COVID-19 vaccines through COVAX facility.
Hello, everyone. My name is Dr. Derrick Sim. I'm the Director of Vaccine Supply and Demand here at GAVI, and I lead the vaccine transactions here at the COVAX facility. I like to introduce the COVAX facility and the vaccine supply program that we have for our participants. COVAX is a coalition of our partner organizations, CEPI, UNICEF, WHO, and GAVI. I will introduce COVAX's key role, our vaccine portfolio, the equitable allocation mechanism, and the future of COVAX as we move through this pandemic. The key role of COVAX is to ensure that we can help participants and countries end the acute phase of the pandemic. We aim to deliver around 2 billion doses by the end of 2021 through fair and equitable access to all vaccines for participants. We are supporting the largest actively managed portfolio globally, and we want to offer a return on investment for the global economy by delivering the vaccines as quickly as possible to our participant countries. To date, $9.8 billion have been raised for the COVAX Advanced Market Commitment to provide funds for vaccine purchases for our most vulnerable low and lower middle income participants. This is against our target of $9.3 billion. We have to date signed 11 vaccine candidates for supply against our target of 10 candidates. And we're aiming to deliver 1.9 billion doses this year. 90% of the COVAX participants have already received the first shipment of their vaccines, and we've delivered approximately 200 million doses out of the 400 million that's already been allocated. And there's obviously more to be shipped in the second half of this year. As I mentioned, COVAX is a coalition of 4 organizations, WHO plays a normative and coordinating role across the entire facility. CEPI primarily supports the R&D and initial manufacturing development activities for their portfolio of vaccine candidates. GAVI plays a leading role in supporting the procurement and the delivery to the countries and engaging with the different participating countries, as well as the donor community for the supply of these vaccines. And UNICEF and PAHO plays roles as the delivery and procurement partners working with countries directly. We cover a range of activities across these organizations, all the way from R&D support to manufacturing scale-up. Clearly then the vaccine procurement and allocation mechanisms, as well as the COVAX procurement logistics and supporting countries with their delivery activities as well. This is a wide range of activities and is enabled by different teams across these 4 organizations. The COVAX facility has 195 participants and donors, and you can see from here that we have a range of countries who participate in different ways. In blue, you see the AMC or Advanced Market Commitment 92 countries. These are 92 participating countries and territories for which donors are supporting the supply of their vaccines. So they receive the vaccines at no cost. In red are fully self-financing participants who actually do pay for their vaccines, but they do participate in the sense of getting allocations of vaccines through the COVAX facility. And then we have a number of countries that you see there in lighter blue who participate as donors. Clearly, some of the self-financing participants are also donors to the COVAX facility. The advanced market commitment countries that are supported by donor funding for their doses are supported several ways. We have the advanced purchase agreement doses. Those are the doses that we purchase directly from manufacturers and have contracts with. As I mentioned, we have contracts for 11 candidate vaccines. In the red, you see also dose sharing, which is the donation mechanism by which countries who have doses that they can donate or share with other countries for equitable distribution can do so via COVAX. And then in the green are doses where the AMC countries who wish to obtain additional doses financed through the development banks, such as the World Bank and the Asian Development Bank, are able to procure additional doses through the COVAX facility as well for their use. So these are the 3 mechanisms by which the advanced market commitment AMC countries can obtain doses through the COVAX facility. The portfolio that we build aims to be broad and diverse. And the reason is that no single vaccine candidate is guaranteed to firstly succeed through the R&D and regulatory process, or potentially has enough capacity to produce to supply the world. And this is the reason why we have a number of different deals and agreements with a range of different manufacturers in order to ensure that we can have sufficient supply. The vaccine candidates that we select for the advanced purchase agreements are based on several criteria. Firstly, on the right, you can see that there are a number of features of the vaccines themselves, which are important, such as the efficacy, immunogenicity, safety, the programmatic feasibility of using these vaccines, as well as the delivery considerations for the particular vaccines. We also look at the portfolio considerations. As I mentioned, we do want a diverse portfolio. We want to ensure that we are sourcing globally from different regions. We want to ensure affordable pricing overall for the facility. And clearly the timing of the delivery and the doses is also important for us. So what you see here is a selection of some of the candidates globally of the COVID-19 vaccines. And you can see in the green boxes that the majority of those at late stage or approved are part of the COVAX portfolio, such as the AstraZeneca Oxford candidate vaccine, the J&J Janssen vaccine, the Pfizer, Moderna, Novavax, Sinovac, Sinopharm, Clover, and Sanofi GSK candidate vaccines as well. We also have been working with several donor governments on dose sharing mechanisms to bring additional doses to the AMC participants. This dose sharing or donations of vaccines will help to increase the coverage of vaccinated individuals in AMC countries. It helps to promote equity, as clearly we see that there are more doses in certain regions of the world compared to others, and we hope to provide that equitable allocation. And this hopefully will ensure maximum benefit for participating countries. The dose donations to date are approximately 300 million doses that are aimed to be delivered this year, with more to be delivered in 2022. You can see here a selection of the donor countries that have elected to share doses with the COVAX facility. These doses are then allocated to the participants, and they are covered under the terms that we would supply the other vaccines that COVAX facility supplies, such as being covered through no-fault compensation programs and indemnity and liability provisions as well. What you see here is the overall COVAX facility, both the supply of vaccines from our advanced purchase agreements, as well as in light blue, some of the dose shared or donated doses as well. You can see that the deals that we have signed will give us up to the potential to have 3.8 billion doses. We have other deals and non-binding agreements that are under discussion that will increase that to a further total of 5 billion doses. And this is the current size of the portfolio. This is obviously subject to considerations such as regulatory approvals, the exercise of optional doses, and successful manufacturing scale-up, amongst other factors. When we look at when these doses will be delivered, you can see here that in the first half of 2021, given that some of the vaccines were still in development, have yet to have received regulatory approval. This was a relatively, modest volumes that were delivered this year. However, as you see, as we move through the months ahead, as more vaccines become available through manufacturing scale-up, through increased regulatory approvals, and just by having more candidates available in the portfolio, we see that these volumes do pick up. So we expect to deliver up to about 1.9 billion doses by the end of this year, which means that about 23% of the populations in the AMC countries could be potentially covered by these vaccines. This projection is obviously subject to a number of factors. As I say, we still have vaccines that require regulatory approval. Manufacturing ramp-up is still in progress for many of these candidates, and there are other, delivery and funding considerations as well. What's actually important is also the allocation. So once we have the supply of the vaccines, and we know the timing of when these vaccines might be available, the question then comes to which countries will receive these vaccines. And there has to be equity in the allocation. So there is a methodology by which the aims of the COVAX facility are to firstly protect the healthcare systems and the key priority target groups in the participant countries and territories. So frontline workers, health and social care workers, and high-risk adults are the priority target groups. And so we want to ensure that the participants firstly receive doses that are proportional to their total population to cover these groups. And then as supply becomes more available, further volumes will go to help them cover other priority groups as well in their population. Countries also need to show preparedness in order to receive the doses. We don't want doses to go to waste. We want to make sure that every single dose is utilized. And you can see here several of the considerations that are checked and discussed with the countries before doses are shipped to the countries. So this way we can ensure end-to-end that the doses are equitably distributed and are being utilized in an efficient way. The future of COVAX, so we're starting to look at where we go from here. The job is clearly just beginning, and we're not yet at the end of this pandemic. In 2021, we want to ensure that we can supply vaccines sufficient to manage this acute phase of the pandemic by protecting the most vulnerable populations. We have built a diverse portfolio of vaccine candidates. We have pooled demand and supply and the resources in order to do this. And we have set up a mechanism for equitable access and allocation, which is enabling the delivery, which is scaling up as we speak. And as you see, there's more to come in the second half of this year. As we move into 2022, we understand that countries have different needs and objectives in their pandemic plans. These largely revolve around controlling the disease and starting to reopen the economies and their societies. So we hope to support that, but ensuring that we continue to manage this portfolio of vaccines, continue to pool the demand and supply in order to meet those objectives, and hope to be able to do this equitably as well. This will require increased support, particularly for the AMC 92 countries as they start to scale out their programs and meet, more ambitious targets as well in terms of the volumes of vaccines that they want and the number of people that they want to reach. So I hope that gives you a good overview on the COVAX facility, as well as the supply and delivery mechanisms that we have in place. And I thank you for your participation at the IVI Vaccinology course. Thank you.
Thank you, Dr. Sim, for this presentation. So since we're a bit ahead of the schedule, I think I would suggest that we have a Q&A session now after the two presentations. I understand that Dr. Derrick Sim will be joining us soon, and Dr. Sylvie Bryan won't be able to make it. And I think Dr. Sim is already on the call. Hi, Dr. Sim. Are you there?
Yes, I am. Hello.
Hi. Hello.
Sorry
thank
for
you.
the connection delay.
Yeah. Can you hear me well?
I can. Thank you.
All right. So thank you for joining us, and thank you for your great contribution to IVI's Vaccinology course. We really appreciate that. I've seen a number of questions coming in. Since you are with us, allow me to take a few questions and address them to you. One of the first questions we got is related to COVAX, of course. That is as follows. Does COVAX only covers the distribution of vaccine? How about global collaboration of vaccine research? Should equity also include equity in opportunity to share vaccine research implementation? Your thoughts?
Yes, thank you for that question. That is part of the COVAX mission as well. Our partner organization, CEPI, which is primarily concerned about ensuring that there are research partnerships which can be supported, both for COVID-19 virus research and vaccine research, as well as other infectious diseases as well. They are working with a number of partner organizations in academia, but also with industry, looking at some of the early phase preclinical research into these disease areas, but also they are working to support some of the post-licensure studies to obtain additional data in specific populations, either in specific epidemiological and socioeconomic situations, or in specific, vaccinee populations as well.
Thank you for the answer. And if I may share our thoughts, as well on this topic, we believe that there's a shortage of good research. In other words, not enough funding still, in terms of studies related to implementation, vaccination implementation and effectiveness in diagnostics and sequencing. So that's something we really are looking forward to, seeing more and more funding coming in. If I may, there's another interesting question we have received. Why COVAX cannot bring vaccine development technologies to developing countries? It's a difficult question.
So COVAX is supporting developing country manufacturers from the point of view of ensuring that the research or the vaccines that they're producing can be considered for use globally. So this has been done in several ways. One, as I said, is the support that CEPI, our partner organization, provides for the vaccine research and development. They also do provide technical assistance on things like manufacturing process scale-up, which some of the smaller manufacturers, not only in developing countries, but also biotechs, they may require. The second way that we do support that is through the procurement process. UNICEF ran a global request for proposal tender process and actually received more than 30 different submissions and applications from different manufacturers around the world. If those vaccines are deemed to be suitable for use by our independent product group, which is an independent group of experts which makes recommendations, and if the vaccines are successfully approved from a regulatory perspective and also receive the World Health Organization emergency use listing and eventually the pre-qualification, then these vaccines will be purchased by COVAX for use globally as well. So there are a number of ways that the developing country manufacturers can certainly access support in the development, manufacturing process development, as well as eventually the potential use and purchase of those vaccines as well.
Thank you, Dr. Sim. There's another question, if I may carry on because COVAX facility is a topic of high interest to everybody, particularly those that are now attending the course. As you pointed out, in 2021, it was aimed at managing the acute phase of the pandemic within a very evolving environment. Are there any lessons learned that you would take into consideration in 2022 to support the country's needs and ambitions to control the disease and to somehow help everybody get back to normalcy to some extent?
Yes, I think in our experience so far, one of the challenges has been the equitable distribution of vaccines. I think we always knew that demand and need would be greater than the available supply of vaccines, at least in 2021. And we see that that is likely to be the case in 2022 as well. I think one of the challenges is ensuring that the available vaccines are equitably distributed. And I think this is why COVAX, with its global scope and the global allocation mechanism, is so important to ensure that we can equitably distribute those vaccines. I think in terms of the lessons learned, I think one of the things that we have seen is definitely the rise of vaccine nationalism, meaning that certain countries in the world, particularly those which host manufacturing facilities, have provided funding support, but also other contractual support to some of these manufacturers and therefore have had a priority on a large number of doses. I think one of the challenges is that we recognize that different governments may provide funding research for their own academic institutes or their own manufacturers as a means to secure doses. However, we believe that definitely a portion of those outputs still need to be equitably shared around the world, as there are not enough manufacturers and supply to go around. So we would definitely urge against the nationalism that we have been seeing, and we would also look at different ways where coverage targets perhaps could be more aligned globally, so that we don't see the inequity of certain countries having quite high coverage rates while others are still waiting to cover even the most essential frontline workers. So that is a situation that we see as an area that continues to need to be addressed.
Thank you, Dr. Sim, for the answers and your great contribution to IVI's Vaccinology course. And maybe before we carry on with the next speakers, one question for WHO or Dr. Bryan, even though she couldn't get connected for the Q&A session. Just one question related to the Mu variant that we all have learned or heard about lately. It was not included in her presentation. And as we have seen, WHO has put in place a tremendous effort to monitor all the variants circulating, and I'm sure we'll be having an update in the coming weeks or so related to the new variant Mu, that is the name, that is now being detected here and there. Thank you for your participation and your questions. Please carry on with your questions and send to us. Now, if we move on for the next speaker, that is Professor Peter Hotez from Baylor University. He will be presenting vaccine diplomacy in a time of anti-science. Professor Hotez.
Hello, I'm Peter Hotez. I'm a professor of pediatrics and molecular virology at Baylor College of Medicine, where I'm also the co-director of our Texas Children's Center for Vaccine Development. And now I'd like to give you an overview of some important aspects of both vaccine diplomacy, but in this very challenging time of what we call anti-science, and I'll explain what that means. So I'll begin now. So thank you. So the title of my talk is Vaccine Diplomacy in a Time of Anti-Science. And just another word about who I am. I co-head with my science partner for the last 20 years, Dr. Mary Elena Bottazzi, and we've developed a portfolio of vaccines primarily for parasitic diseases at Texas Children's Hospital and Baylor College of Medicine. Texas Children's Hospital is actually the world's largest children's hospital. We do everything in a big way here in Texas, and our group is in the research building. And about 10 years ago, we adopted our coronavirus vaccine program because at the time, the coronavirus vaccines were almost orphaned like our parasitic disease vaccines. And, we've seen enormous progress in our ability to vaccinate the world's children beginning in the year 2000 through the GAVI Alliance that was initially launched by the Bill and Melinda Gates Foundation, of course. And this has had a dramatic impact on reducing the number of children who die annually from vaccine-preventable diseases, really extraordinary numbers, with an 87% decline in measles and things like pertussis, diphtheria, meningitis. But in a new book that I've written called Preventing the Next Pandemic, Vaccine Diplomacy in a Time of Anti-Science, I point out that some of those global health gains have started to unravel, and they've unraveled because of things that as biomedical scientists and public health experts, we don't ordinarily think about, things like poverty and war and political instability, urbanization, deforestation, climate change, and this very aggressive rise in anti-science. And this was published by Johns Hopkins University Press, and those are some of the individuals who've helped me with the publishing of the book. And one of the key points is even before COVID-19, there was an unraveling of our ability to vaccinate the world's children, and also a rise of neglected tropical diseases. And the book identifies about 7 or 8 hotspot areas where the rise has been very abrupt. For instance, on the Arabian Peninsula, where I served as a U.S. science envoy for the State Department and the White House during the Obama administration, we've seen how the return of conflict in Yemen, and also the ISIS occupation and the Syrian conflict collapsed health systems to bring back measles, in some cases even polio and leishmaniasis. But it combined also with unprecedented temperatures of 50 degrees Celsius or more, or what Jeffrey Gettleman calls the Africa's unwars. It means not wars as we think of them between armies, but really armed banditry upon the civilian population in northern Nigeria has brought back vaccine preventable diseases. Or in Central Latin America, in Venezuela, with the collapse of the Maduro regime, the socioeconomic collapse, which has brought back malaria, people working in the illegal gold mining industry because of and having to sleep outdoors, attacked by malaria-infested mosquitoes, or the return of measles, which has then been spread across the South American continent because of people leaving Venezuela in large numbers into the Amazon region of Brazil, or into Colombia, where the virus has also hit indigenous people really hard, or Texas and the Gulf Coast, where not so much political instability, but climate change and urbanization and this rise of anti-science to bring back disease. And that's the setting where COVID-19 emerged. So, people like to think of COVID-19 as an extraordinary event. I think of it more as a capstone event or a culminating event because of years of political instability. And of course, now the Delta variant is dominating globally and is spreading with a transmissibility far higher than anything we've seen before. And it's hitting big pockets of unvaccinated populations in the United States as well, particularly in the southern part of the U.S. or in some of the Mountain West. And in a minute, I'll talk about why these areas of the country are so unvaccinated compared to very successful vaccination programs in the Northeast and in the West Coast. And of course, globally, we are still profoundly underachieving in our ability to vaccinate against COVID-19. Right now, the African continent is largely unvaccinated, and South America, Central America is still underachieving in many parts of Southeast Asia. So as long as we continue to withhold vaccines from many regions in the Southern Hemisphere, we'll continue to experience the acceleration of COVID-19 from the Delta variant and from variants to come. And here's the extent of the problem, which I think not many people really articulate, the enormity of it all. We face more than 1 billion people in sub-Saharan Africa without vaccines, 650 million people in Latin America, 500 million people in the smaller low-income Asian countries. We're talking more than 2 to 3 billion people that require 5 to 6 billion doses of vaccines. And I think the point here is simply asking the G7 countries to share their vaccine supply is not going to be adequate, because there simply is not enough vaccine to go around to immunize 6 billion people. And so I like to make the point that we went very heavy on innovation, which produced some great vaccines. The mRNA vaccines, I myself got the Pfizer Biotech vaccine, and as well as the adenovirus vectored vaccine. But I sometimes think that we went so heavy on innovation that maybe we didn't give enough consideration to having some simple, durable vaccines that we could scale up now to vaccinate the world by the end of 2021, or the way I sometimes say it, we went so heavy on the shiny new toys on the bottom right that we forgot about the old school toys like Matchbox cars for the world. And it's not that it's either or, we need both, of course, but the point is, if there's urgency now to scale up, I think we have to consider that. And this is what we're doing. We have embarked on a collaboration with PATH, the Program for Appropriate Technology for Health in Seattle, which has done so much great work with the Gates Foundation for a meningococcal vaccine, malaria vaccine. we've been working primarily on recombinant protein vaccines, similar to the hepatitis B vaccine that's been used to vaccinate the world for decades, and this is produced in yeast, and we've now partnered with Biological E, one of the big vaccine producers in India, and this is now finishing phase 3 trials, and the hope is that fairly soon we will have emergency use authorization in India with a commitment from the Indian government to advance purchase vaccine. So that's underway, and this is is about as straightforward a vaccine as you can imagine. It's that goes under the trade name in India known as Corbevax, the BE for biological E, and it's the receptor binding domain of the SARS spike protein in yeast and Pichia pastoris on aluminum hydroxide together with the CPG oligonucleotide from the Dynavax Corporation. So we developed the processes for the initial seed production and the production cell bank, which was then technology transferred to Biological E, and now we've been working with them very closely in terms of scale-up production and now finishing phase 3 testing, regulatory filing, and hopefully emergency use soon. And this has been kind of an interesting role for us. We talk a lot about vaccine diplomacy between countries. Well, this is vaccine diplomacy between Texas and our research group and India, and now Indonesia, and we're in discussions with several other countries all over the world in order to accelerate production of this vaccine, which has the ability to be scaled in a fairly straightforward manner, very much like the recombinant hepatitis B vaccine. Now, the other hat that I wear, in addition to helping to lead a group in vaccine development, is the opposite, to counter this very aggressive rise in anti-vaccine, anti-science forces. And this has been a long-standing battle of mine because I have in addition to being a vaccine scientist, I have a daughter, Rachel, has autism and intellectual disabilities, and a few years ago wrote a book called Vaccines Did Not Cause Rachel's Autism, which made me a major target of the anti-vaccine lobby. So by default, I became an expert not only in vaccines, but anti-vaccines and anti-science. And not many people are aware of how this has evolved, at least in the United States, and now is proceeding globally. So version 1.0 started over 20 years ago when there was assertions that vaccines had the ability to cause autism, beginning with the MMR vaccine. And then it shifted. That thread of vaccines causing autism remains with us today. But a few years ago, it took on a political dimension here in the United States under this banner called health freedom or medical freedom. And this is what's causing so many of our problems in the US today. And now there's version 3.0 that I call globalization or creation of the anti-science empire. So let me quickly take you through those three aspects. So with regards to vaccines causing autism, that in itself has complexities because the assertions from anti-vaccine groups have changed. It was initially about claims that the measles, mumps, rubella vaccine, the MMR vaccine cause autism, and our scientific community responded in a big way, showing that kids on the autism spectrum were no more likely to get MMR vaccine than kids not on the spectrum. Similarly, kids who got the MMR vaccine were no more likely to acquire autism later on. But then as we debunk that, the scientific community, the anti-science groups said, no, we didn't mean MMR vaccine. Maybe it's the thimerosal preservative. And once again, the scientific community responded. So we got into this habit of where the anti-vaccine groups kept on moving the goalposts. As soon as we were close to debunking it, they would switch the assertions. Then it became spacing of vaccines or alum in vaccines. And in some cases, even getting away from autism entirely, focusing on the HPV vaccine for cervical cancer and other cancers, claiming it caused infertility or autoimmunity. And if that sounds familiar about the assertions about COVID-19 vaccines, that's deliberate because they copy-pasted the fake assertions about HPV vaccine onto COVID-19 vaccines. And of course, I got involved in this because my wife Ann and I have our youngest daughter Rachel is now an adult. with autism and intellectual disabilities. And I wrote in detail the evidence showing there's no link between vaccines and autism, and also what autism is and how it begins in early fetal brain development. And we talk about doing whole exome sequencing on Rachel and my wife Ann and I, and identifying an autism gene that's similar to the 100 others that have been identified involved in excitatory inhibitory neuronal lineages and in synaptic connections. And you pay a price for that because the anti-vaccine groups are pretty aggressive. I'm officially, they call me the original gangster villain, the OG villain. So thank you for inviting the OG villain here today. This has been an ongoing struggle. But then what happened, I think, in part because we've been able to diffuse some of the assertions about autism, the anti-vaccine groups needed to find a way to re-energize. And in the US, it happened in a very interesting way. And starting around 2013, 7-8 years ago, so many kids were opted out of being vaccinated by their parents because of fears about autism that this created measles epidemics in Southern California, including a very large one in Orange County. And this caused the California legislature to say, look, if you want to send your kids to school now, you have to have your child vaccinated. And in response to that, this took a libertarian side under this banner of health freedom, medical freedom, saying you can't tell us what to do about our kids. And it took on this political dimension, and it really accelerated in Texas, where I am, where so many kids were denied access to their vaccinations because a political action committee formed that was linked to the Republican Tea Party. And so the Republican Tea Party basically adopted an anti-vaccine, anti-science platform. And it was especially centered around the Austin, Texas area where so many kids were denied access to their vaccines. And this is what we're dealing with today, why we have this very sharp political partisanship around not getting vaccinated, very much linked to conservatism or even the right wing of the Republican Party. It was initially sort of a political extremist group on the far right, now has become more mainstream. And the reality is this: when you look at where people are not vaccinating, it's very much along a partisan divide. So in the way we use the term blue state and red state in the US, blue refers to Democratic state and red refers to conservative or Republican state. And you can actually guide your percentage of vaccinations by whether or not it's a blue state or a red state. And it's very self-defeating. And it's also very uncomfortable for us to talk about as scientists because, our training is not to talk about Republicans and Democrats or liberals or conservatives, but that is the reality. And what I have found, there's no way to talk about this unless you talk about it. And there's no hope of really tearing out the anti-science out of the Republican Party unless you can have a very frank conversation about this. So this has been a major activity of mine in the cable news networks now, is trying to explain why anti-science doesn't belong in any political party and how we need to go about delinking it. But that is the reality. And unfortunately, now the US has exported this and it's gone global. So those same far-right anti-vaccine, anti-mask rallies that we had in the US last year extended to London, Berlin, and Paris. And the New York Times and the BBC reported it's linked even to QAnon and political extremist groups on the far right. And of course, that's not complicated enough when we have this additional problem now that the Russian government is participating in this. So the Putin government has been using anti-vaccine, anti-science as a wedge issue to further divide our country. And there's even been a term ascribed to it called weaponized health communication. So this has become a very complex ecosystem that I call the triple-headed monster, which includes state actors such as the Russian government under Putin, far-right extremism and political action committees that are becoming mainstream across the GOP, that stands for the Republican Party, and U.S. based anti-vaccine non-governmental organizations. And there's an organization called the Center for Countering Digital Hate. It's incredible we have to have an organization like that. Estimates that they have now 58 million followers, the 12 leading groups. So it's very much a triple-headed monster. And I've been trying to work with the Biden administration about how we really tackle the disinformation anti-vaccine monster that's causing so much damage, and the fact that we have to have a frank reckoning that this has now gone global. And I make the point that when you think about efforts that we build infrastructure to fight things like global terrorism or cyber attacks or nuclear proliferation, we understand how we need to devote resources to build infrastructure to combat these things, but we haven't done this for anti-science. And I counter that anti-science is far more deadly. The reason why 614,000 Americans have lost their lives from COVID, yes, it's due to the SARS coronavirus type 2, but in equal measure, it's due to defiance around masks and social distancing and now vaccines. And we've got to find a way to build infrastructure and capacity and get help from outside the health sector to advise us on how we go about doing this. So thank you for this opportunity. I know there's some sobering comments towards the end. We have our work to do, but I appreciate the opportunity to be part of this very important vaccinology initiative from the International Vaccine Institute that I first visited back in the 1990s. So I've had an incredible passion for helping and supporting IVI for many, many years, even decades. So congratulations to Dr. Kim and the IVI team, and thank you for the honor of letting me speak to you.
Thank you, Professor Hotez, for your presentation, as well as your outstanding and continued support to IVI. It's with a great pleasure that I'd like to warmly welcome Dr. Jakob Cramer from CEPI to give us an update on COVID-19 different vaccine platforms and development.
Good morning, everyone. My name is Jakob Cramer. I'm the head of clinical development at CEPI. And thank you very much for inviting me to present at this very interesting meeting here today. My topic today will be COVID-19 vaccine development, different platforms, what are evidence gaps moving forward, and what are challenges and differences across those vaccine platform technologies. Let me quickly share my screen. So let me start by reviewing the platform technologies which we actually have in our vaccine pipeline. And broadly, these COVID-19 vaccines can be divided into 4 major platform technologies. First of all, on the upper left-hand corner, nucleic acid vaccines based on mRNA technology or DNA technology. You inject the information into the cell, and the cell itself is producing the antigen to which the host is then eliciting an immune response. The more classical vaccine approach, subunit vaccines that generally need to be adjuvanted with immune adjuvant substances, are summarized on the upper right-hand corner, a fairly long list of antigens and different antigens being used. The lower left-hand corner summarizes viral vector vaccines, where nucleic acid is actually injected, or a viral replicating virus is injected and then eliciting an immune response to targeted antigens. And again, more traditional approach on the lower right-hand side, whole virus inactivated vaccines. So the actual virus is taken and inactivated and then injected to elicit an immune response. The 3 platform technologies, mRNA, subunit vaccines, live virus vectored vaccines, all share the fact that they have a selected antigen that is being expressed, mostly the glycoprotein, the spike glycoprotein, either in full length or just the receptor binding domain, whereas the whole virus inactivated vaccines express other antigens included in the virus. Those individual candidates marked in green here are those that have already provided vaccine efficacy data or are already licensed. This is the portfolio that CEPI, the Coalition of Epidemic Preparedness Innovations, is actively supporting. And you can see by the colored schemes across clinical development phases, we cover a series of different platform technologies. We have been supporting so-called first-generation vaccines, some of them being used and licensed. You're well aware of the AstraZeneca University of Oxford vaccine, the Moderna mRNA vaccine, but we are also supporting other platform technologies that have all advanced through clinical development, are partially already in vaccine efficacy trials at the moment. We also look at second-generation vaccines. We call them Wave 2 products, again, across different platform technologies, to see if we can improve existing vaccines or come up with additional manufacturing capacities, and so on. So we are looking into additional vaccine platform technologies as well. Several attributes are important for us when we access vaccine technologies. Of course, immunogenicities or biomarkers for efficacy are important. Safety tolerability profile is essential, of course, but we also look into dosage, the concentration needed on the number of doses necessary to mount a good immune response, because, as you all know, this has a direct impact on vaccine supply. Manufacturing productivity is important as well. Even if we need series of doses to elicit a good immune response, if there is a huge manufacturing capacity behind this, this would still be beneficial for overall supply. Thermal stability, the best vaccine still doesn't do any good if it is very complicated to deliver the vaccine into remote areas. Cold chain aspects, for example, storage conditions, some of the vaccines have to be stored at freezing temperatures, which obviously in the context of tropical climate areas is quite a challenge. I'll come back to this in a second. Cost is relevant, the history of the technology, the capacity, the experience of the manufacturer, and then finally experience and data that we can potentially leverage on to accelerate regulatory approval. Now, to look into these platform technology a little bit closer, I have summarized a few characteristics here on this slide, and let me start with the viral vector. It's fairly those can be developed and adapted to new antigens in a very comparatively fast manner. The vaccine technology is fairly straightforward, which has a good impact on cost. The production capacity is fairly high, and as I mentioned, the stability, the storage conditions are advantageous. Those vaccines can be stored for quite some time at normal refrigerator temperatures. RNA vaccines can be adapted to new antigens very quickly as well. The cost is fairly high, and this is not necessarily related to the RNA molecule itself, but to the liquid envelope, which is necessary to actually get the RNA into the cell. This is a fairly complex technology with limited production capacities at the moment, which also limits the scalability still, but we do hope that there will be an improvement in LNP, liquid nanoparticle production in future. But these liquid nanoparticles themselves are also affecting the stability and storage conditions, and you're probably aware that some of the RNA vaccine require freezing, not just as regular freezing temperature, but really at high deep freezing, -60 to -80 degrees Celsius. DNA, again, similar to RNA, can be adapted to new antigens fairly quickly. Cost is high. Scalability is fairly high, but the stability is much better as compared to most of the RNA products. The more traditional approaches, protein-based and inactivated live attenuated vaccines, again, need some time to develop and adapt to new antigens. The production capacity, depending on the medium, the cell culture that is being used, for example, to amplify virus, is a fairly complex technology and limits the production capacity. Once this is established, however, and there is a good functioning protein expression platform, for example, the scalability can reach huge dimensions and allow, rapid and very high production capacities. Storage conditions, again, comparatively favorable. So there is by no means the one and only optimal vaccine platform technology moving forward. What about the immune response? The immune response itself differs, and I'm showing here data that a colleague of mine in Germany has shared with me from a study that was conducted mainly in solid organ transplant patients, but I'm showing you here some data from healthy controls after the first dose of the AstraZeneca vaccine as compared to the Pfizer-BioNTech vaccine. And as you can see on the right-hand side, the upper panel shows the IgG. And the immune response roughly around 13 to 18 days after the first single dose differs if you look at the viral vector as compared to the mRNA vaccine, in that the IgG antibody level is significantly higher post-mRNA as compared to the viral vector vaccine. If you look at the neutralizing antibody titers, that confirms that tendency. However, and that's the point I'd like to make, if you look at cellular immune responses, for example, CD4 cells or CD8 positive T cells on the right-hand side, you can see that the viral vector vaccine are much better. So what is it that we need? What type of immune response do we need? This is pathogen dependent. Some pathogens rely on a good cellular immune response. Maybe the cellular immune response is more important to prevent progression from infection to severe disease. Various high antibody titers are more important to prevent transmission and infection per se. So it really depends what type of pathogen we look at, but also what our primary public health goal may be. Is it prevention of disease, keeping people from dying out of hospitals? Or is it, on the other end, the intention to have an effect on transmission, on infection, to end the pandemic per se? Let us deep dive a little bit further into the mRNA technology. mRNA vaccines, we have seen two mRNA vaccines being licensed, the Moderna vaccine and the Pfizer-BioNTech vaccines, and there's a lot of additional vaccines still in the pipeline. However, mRNA vaccines cannot be directly compared to other mRNA vaccines. Of course, I've listed here in this box, in the gray box, a few characteristics that differ from mRNA candidate to mRNA vaccine. Of course, the antigen concentration, the amount of antigen of mRNA that is included in the vaccine differs significantly, and I've put a few up here on this scale. CureVac, for example, contains 12 microgram. The Pfizer-BioNTech vaccine, which is being used widely, contains 30 microgram of RNA, and the Moderna vaccine has 100 micrograms of mRNA included. You can see a few additional mRNA candidates here on this plot as well. But in addition to the RNA concentration, there's a lot of other characteristics that are very important. Some of the mRNA vaccines express the full-length spike glycoprotein. Others, just the receptor binding domain. There is base-modified mRNA vaccines and unmodified mRNA vaccines. The base modification is insofar important as some of the nucleosides trigger a cellular immune response when these mRNA vaccines are injected into the host. This triggers obviously some side effects and reactogenicity and may lead to inactivation of mRNA before the actual protein is expressed in the host cell, eliciting a targeted immune response. So base modified and unmodified vaccines could have quite an impact. The CureVac vaccine, which, as you all know, did not reveal very good results in phase 3, is an unmodified vaccine, whereas the two vaccines that have shown more than 90% vaccine efficacy against any severity COVID disease are modified mRNAs. There is concepts related to non-amplifying and self-amplifying mRNA vaccines, and then, as I already mentioned, the little blister, which includes the mRNA and kind of serves as a vesicle to inject the mRNA into the cell. Those liquid nanoparticles also differ between mRNA vaccines. Nevertheless, mRNA is a platform that you can use to express or to include new antigens very rapidly. And we were very successful in this COVID-19 pandemic, as shown on this slide. The sequence of the new SARS-CoV-2 pathogen was released on 12th January 2020. Only 9 weeks after that, Moderna started to go to express an antigen and started the phase 1 dose selection trial 3 months later. Pfizer followed in May. And only a few additional months later, July 27th, both Moderna and Pfizer started their phase 3 trial, which allowed us to see and review vaccine efficacy data less than 365 days after the sequence was actually released on November 16th for Moderna and November 9th of Pfizer Biotech. And as you all know, first emergency use authorizations and vaccine licensures were obtained in less than 1 year after that very new pathogen had been characterized. Nevertheless, there's still some challenges that lie ahead for mRNA platforms. I mentioned the productivity more for the lipid nanoparticles maybe than for the mRNA itself. We need to improve thermal stability, in particular if we think globally and would like to provide these very effective vaccines on a global scale, and also to improve tolerability. Some of them, particularly post-second dose, have shown some reactogenicity, all still, I think, within acceptable boundaries, but still compared to other vaccines, the reactogenicity was described as somewhat more occurring more frequently as compared to other vaccine platform technologies. Now, I would like to highlight a few aspects that we still need to clarify across platform technologies. The COVID-19 or the SARS-CoV-2 virus is a fairly new virus, and we have limited experience from vaccinology. We have never used a vaccine against coronaviruses so far. We do not know if there is a correlate of protection. Since more and more countries are rolling out vaccines now and using vaccines in their population, it becomes increasingly difficult to conduct placebo-controlled vaccine efficacy trials in these populations to establish vaccine efficacy for new second-generation vaccines. There is several papers that have been published lately showing a very good correlation between neutralizing antibody titers and protective vaccine efficacy. On this graph, this is a publication by Corey et al., but there's another one by Christine Earle as well, plotted the neutralizing antibody levels on this graph and compared this with protective vaccine efficacy. You can see that mRNA vaccines, BioNTech, as well as here the mRNA 1273, which is the Moderna vaccine, elicited very high neutralizing antibody titers and also sit in the above 90% frame for vaccine efficacy. Whereas other vaccines, the viral vector vaccines like AstraZeneca, had somewhat lower neutralizing antibody titers, which translated into somewhat lower vaccine efficacy. And then at the lower end are so far the whole variant inactivated vaccines, CoronaVac, for example, which translated in somewhat lower vaccine efficacy. I have to state, and I would like to make very clear, that this is vaccine efficacy against COVID of any severity. All of those vaccines still have a very good vaccine efficacy against severe disease, which might be our primary goal in this pandemic. We have started vaccinating populations. Most vaccinations are based on 2 doses for primary immunization, but we faced, supply issues. We are moving forward. Are we able to provide exactly the same vaccine for second dose, or should we actually provide the same vaccine as second dose? You know that some safety events have been described, thrombotic events, for example, which triggered, some countries or public health authorities to recommend a separate dose, a different vaccine for second dose. But we need to generate data on this. Can we improve with heterologous priming and boosting? So using 2 different vaccines for priming, or after priming with a single vaccine, giving a different dose for boosting some months later. Is this something we can do? Is there any disadvantage? Or potentially, is there even an advantage in triggering different immune responses? So first data are now being published on heterologous priming, in particular, for example, from the Oxford group, and I'm showing some data. Just look at the upper left-hand graph and the lower right-hand graph. And you see here 4 regimens that have been tested. First of all, in yellow, 2 doses of the AstraZeneca viral vector vaccine, and in, I think it is green, 2 doses of the Pfizer BioNTech vaccine. And then in red is the regimen where first an AstraZeneca vaccine had been given, followed by the Pfizer vaccine 4 weeks later. And in blue, the other way around, first dose Pfizer vaccine, second dose AstraZeneca. And the point I'd like to make is that both Pfizer vaccine given for both doses, but also Chaddock's vaccine priming and then followed by Pfizer vaccine elicit a very, very high antibody titer, higher than the other regimen shown here on the upper left-hand figure. However, and that's again what I mentioned earlier, if you look at the cellular immune response, the best regimen seems to be the priming with the viral vector vaccine, followed by a second dose of Pfizer. And there is more data coming up supporting this. And I think this is even data very relevant for vaccinology beyond this COVID-19 pandemic. What about boosting? We know that in particular for the mRNA vaccines, the antibody titers decline rather rapidly. That does not necessarily translate into reduced vaccine efficacy because natural infection based on immune memory may boost very rapidly another immune response. But it is still important to look what has to be done and what can be done in terms of boosting. What is the type of immune response that we actually need? Is it antibody titers? Infection transmission, potentially, is it cellular immune response, progression to severe disease? What is the duration of the immune response? What would be a perfect timing for a booster if it is necessary? Is it really a booster, or is it rather a 2+1 regimen? Do we actually need a third dose for some of these vaccines that are either weakly immunogenic or show a rapid decline in antibody titers? Just think of hepatitis B, where you give 2 doses 4 weeks apart and then a third dose 6 to 12 months later, which is actually a 2+1 regimen rather than a first booster. Should we give different vaccines for booster? And to which population should we consider giving booster vaccinations? All, or just some? Maybe immunocompromised will need a third dose. Older adults, immunosenescence may require a third dose. Chronic diseases, what about weakly immunogenic vaccines? I mentioned that, require a third dose. To cover against variants, new variants, how does this translate into clinical efficacy? Is this a full dose or a reduced third dose? And what about safety reactogenicity? So you can see a lot of questions still have to be answered. And certainly moving forward, the field has become more complex. The good news is that most of these vaccines platforms are boosterable, and that applies both to whole variant inactivated vaccines. There's a lot of data that have been shown now that a third dose of whole variant inactivated vaccines given 6 months after priming elicit a very good immune response, which is much higher than the immune titers that have been described immediately after priming. Same applies to Moderna and Pfizer vaccines. Moderna has already published first data from a booster vaccination study in which half dose formulation was used, eliciting a very good immune response. This is something I'd like to share with you as well. This is a publication actually by an economist, Michael Cramer's group, who pledged for reduced dose regimen. And this is again the same graph which I showed earlier to you by Khoury et al., where they plotted the neutralizing antibody titers over the vaccine efficacy. And if you look at phase 1 data and the immune response, for example, for the Moderna vaccine, which has tested a 50 microgram but also a 25 microgram dose level in phase 1, and if you look at the antibody titers that were achieved, this would still, if we assume that there is a true correlation between neutralizing antibody titers and vaccine efficacy, this would still range in a very high vaccine efficacy area. So there is maybe room for reduced doses, in particular when we move forward to booster doses. And this is again something that we need to generate data on. So I would like to summarize and conclude by saying that, of course, more vaccine and vaccines are needed. So we need more quantities of vaccine to serve the global population, but maybe we also need additional vaccine types to improve the immune response, prolong the immune response, and assess optimal heterologous vaccination regimen. There is an increased complexity. Last year, when first vaccines went through phase 3 clinical trials, there was a perfect match between circulating SARS-CoV-2 strains and vaccine-contained strains, as you know, which triggered or produced these very high vaccine efficacy target estimates. However, and the world's population was mostly immune naive. Now, this has obviously changed in 2021. We have a lot of variants of concerns. We know that antibody titers are reduced. Neutralizing antibody titers of existing vaccines are lower if you test them based on these new strains, but this still seems to translate today into good vaccine efficacy against severe disease. Populations are now primed either by vaccination or by natural infection. We know from clinical trials that we are supporting that even in unvaccinated populations, the baseline seropositivity is already very high, assumingly via natural infection. So do these full dose, 2-dose regimens still apply for priming, or is this now a time or sometime in future where we need to move on to fractional or different reduced dose regimen? Heterologous immunization regimen, I mentioned, booster of the general population, or third dose 2+1 regimen in selected special populations. And what about safety signals and reactogenicity? Is this something that we need to keep an eye on in the times when more and more persons are primed and then still vaccinated with full dose regimen? Let me stop here, and I thank you very much for your attention.
Thank you, Dr. Jakob Cramer, for this very good presentation. I think I'm now joined by Dr. Cramer for the Q&A session. I won't be having Professor Hotez given the time difference. Jakob, are you there?
I'm here. Can you hear me?
Yes, I hear you well. So thank you again for the great presentation, and for the participants. All the presentations will be shared, of course, with the students and participants. As you can imagine, Jakob, there are a lot of questions coming in already related to your very nice talk. One of those is related to the platforms, as you can imagine. So would you please comment in which platform vaccine has the most potential for vaccine development of the next generation that will address the question on emerging strains?
Yeah, thank you, Anne, for this question. This is something that we look into. I mentioned that CEPI is investigating into wave 2 vaccines, which it would be nice, single dose regimen, more broad vaccination coverage, immune response against new SARS-CoV-2 variants. CEPI is even more ambitious. We would like to develop vaccines that are not only broadly covering SARS-CoV-2 variants, but at best even other beta coronaviruses. So we are looking into broadly protective beta coronavirus vaccine approaches now. And I wouldn't say that we are specifically hoping for a certain platform technology. Of course, mRNA is interesting. You can rapidly adopt, and there is first investigations now into multivalent mRNA platform technology. So this would be a next step. Keep in mind that this is not just the very first vaccine against coronaviruses. This is also the very first time that we are actually using mRNA-based vaccines in human mankind. This is not exaggerating. So the next step is to go from monovalent to bivalent vaccine and see how the immune response would work. So multivalent vaccines, and platform technologies is something we have to look into, but also the antigens itself. Still, even if you go from mono to bivalent vaccines, for example, it's still the spike glycoprotein or the receptor binding domain within this protein that is included. But we have to look at other antigens and other proteins, epitopes in this virus, or even combining several epitopes to, in the end, find a vaccine platform, an administration route, but also a combination of antigens that would then in the end allow us to elicit a more broadly protective vaccine efficacy.
Thank you, Jakob. I have another question related to the booster dose, as you had mentioned, whether it's a 2+1 or booster dose. Do you foresee that there will be a requirement to have additional doses, a third one, for all platforms?
Yeah, so I want to make very clear that CEPI's focus, or CEPI/COVAX focus right now, is not to look into booster doses for the general populations. We believe that the priming with the existing vaccines and the currently used vaccination schedules provides a good and long enough. I mean, we only started vaccinating less than 9 months ago. So that's all we know about the follow-up and the duration of the immune response, but also of the vaccine efficacy or effectiveness in real world. So at the moment, we believe that priming or complete series of primary immunization is good enough in the healthy population. But that does not mean that we will have to look into special populations, and that's what we are currently focusing on. We know that neutralizing antibody titers, which is currently used to license and to look into and to describe vaccines, decline rapidly. We also know that other immune responses, like cellular immune response mechanism, play a role as well. So there is special populations, immunocompromised, elderly, that potentially do need an early booster, and there is in particular other vaccines that show a rapidly declining antibody titer, and from a purely immunologic point of view, it does make sense to give a third dose, a kind of a 2+1 regimen, as we know for hepatitis B vaccination, for example. And so from a pure immunologic point of view, it makes a lot of sense to give that third dose, and in particular, and that's what we are focusing on, to those populations that may be in need or more in need, at risk maybe even for severe COVID-19 disease. And that is something that we would like to generate data on. But again, the healthy populations, the general healthy populations, should be well covered for quite some time. Careful here with pointing at a certain duration, but for now should be covered very well, and that's not our focus. And you have heard Dr. Tedros some time ago on this matter as well.
All right, thank you. Another question, if I may. You had really listed down all the challenges that researchers, developers are now facing. The environment has changed dramatically in a short time frame, a year or so. It's not the same background, same virus circulating. It's very heterogeneous now. And in terms of ethical and scientific challenges, we know there are a lot still. And there's this publication you had mentioned on the collateral protection, and I want to prime the audience on the topic of emergical collateral protection tomorrow. I know that there have been a lot of efforts at your level as well as the international organization level to look into the collateral protection. That will be, I would say, a good news for all of us. Designing the clinical trials, we can no longer do placebo control design to show efficacy, even though it's the most robust design for regulators, but we can no longer do that for ethical reasons. We have alternative with the non-inferiority design, but when will we expect to have the magic number for the collateral protection, if it's linked to neutralizing antibodies only for the protection?
Yeah, I think what we learned is that we have a good correlation. So we have a good quantitative correlative protection in these neutralizing antibody titers, which is great news. There was first regulators, as you know, have accepted the immune response to licensed adapted vaccines, but based on the same platform. But first, regulators have also accepted neutralizing antibodies to bridge from an existing vaccine to a new vaccine, even across platform technologies. I think this is there's more and more evidence supporting this approach. I think we will not find that one cutoff level in neutralizing antibodies that protects everyone. And we kind of already know that this is not going to be the case. As you know, for example, for polio, if you have antibodies, you are protected. Although there's different, antibodies, for infection and disease. So we will probably not find that. And we also know that cellular immune response, as I mentioned in my presentation, plays a role as well, certainly with regards to progression to severe disease. But at first, there was a lot of arguments. Can we use these neutralizing antibody titers and this good correlation between antibody titers and vaccine efficacy across platform technologies? And evidence as it accrues supports that. Now, obviously, additional questions arise. Can we deploy these findings to new variants as well? How do antibody titers correlate with other endpoints, for example, transmission or severe disease? And there was a WHO consultation just last Friday, 5 hours, on just correlates of protection. And it was mentioned that, and shown actually, that the correlation which I showed is even stronger if you look at severe disease and not disease of any severity. And then finally, we know this from influenza, for example, that this 1/40 titer that is usually considered as a correlate of protection is probably applicable to healthy adults, but not so good applicable to children, and even less applicable to older adults. So we will, apart from looking at the immune response and correlating this with clinical endpoints, we have to look across different endpoints, across platforms, across technologies, but also across SARS-CoV-2 variants. And further data will accrue. And if this continues to point in that same direction, that will be, providing more confidence to use or to go down this regulatory approach, and maybe even eventually, at least for the same platform and variant adaptation, in the end, we can license, if there's new variants and we would like to adapt the vaccine, we can license an adapted vaccine for booster simply because based on the immune response, without doing any immunobridging or placebo-controlled trials, like we do or did every year for seasonal influenza.
Thank you.
But I'm only speculating. We're not there yet.
Not yet. Maybe last one, if I may. I've seen CEPI has set a very ambitious goal to develop a vaccine within 100 days. Even though it was already a scientific breakthrough with the first generation and subsequent generation of vaccine being developed within 300 days. How are we going to do that? I mean, we got this massive global mobilization to develop vaccines with all the stakeholders to make it happen within 300 days. How are we going to make it happen again in a shortened time frame within 100 days?
Yeah, so this is, I have to say, this is our moonshot goal. It's an aspirational goal. And the background simply is that we looked into the case fatalities, and there was already, I think, over 1 million case fatalities 3 months after the disease started. So that's where we came up with this 100-day goal. Time is essential in pandemic situation when the virus spreads significantly. Now, what we did to achieve 300 days is we did a lot of things in parallel. We didn't, no shortcuts, of course, but we already invested in manufacturing capacities before we even started phase 1, for example. That's not something you usually do. So a lot, strings were started in parallel, manufacturing capacities, clinical trials, and other things. And that allowed us to achieve first registrations and interim analyses on vaccine efficacy within 100 days, within 300 days. Now, 100 days is not a result of accelerating this further. 100 days would really be a paradigm shift. And in the end, the key term is risk-benefit assessment. So if we know a lot about the platform technologies, if we know a lot about vaccines based on that same platform technologies, and if we know or anticipate a future disease might again be caused by a new coronavirus, SARS-CoV-3, for example, then we know how a certain platform technology works on SARS-CoV-2, for example. And so we need all of this data on this vaccine platform, which we haven't had when this pandemic started. On the other end, the risk, if there is a very dangerous disease with maybe, SARS or the SARS-1 virus had a case fatality rate of 50%. MERS, another coronavirus, has a case fatality rate of around 30-40%. So if we had a transmissible vaccine like SARS-CoV-2 with the case fatality rate of SARS-CoV-1 or MERS, then we would probably be willing to approve a vaccine much quicker based on viral libraries, prototype vaccine approaches in just 100 days. And we also have to look into manufacturing capacities and starting to produce a vaccine in 100 days. And that is the approach we'd like to invest in. So we will look into viral families in vaccine libraries. We will go down prototype approaches. We have to discuss the benefit risk assessment approach with regulatory authorities and other health, WHO, for example, and see if such an approach under certain scenarios and conditions is something that we can actually develop.
Thank you, Jakob, for your support to the Vaccinology course. Very much appreciated. Thank you.
An honor to contribute. Thank you,
Thank you. So let's move on to the next speaker. I would like to welcome Dr. Sander from UHN Research to speak about the lessons learned of vaccine rollout in Canada.
Hello, my name is Beate Sander. I'm a scientist at the University Health Network in Toronto and associate professor at the University of Toronto. I'm also a co-chair of the Modeling Consensus Table for COVID-19 in Ontario and Canada, as well as a member of the Science Advisory Table and a member of the National Advisory Committee of Immunization. I will speak today about the COVID-19 vaccine rollout in Canada and lessons learned. I will start with key messages for the presentation. So basically in Canada, we had 3 waves of COVID-19 so far. We are now starting in our 4th wave. Our approaches in terms of mitigating the impact of COVID-19 has differed across the different provinces and territories, from mitigation type of strategies to near zero type of strategies. We started vaccination in December 2020, and we now have very high vaccine coverage. And so this will be the focus of this presentation. Generally in Canada, immunization programs are shared responsibility across national, provincial, territorial, and local public health agencies. The National Advisory Committee on Immunization, or NACI, plays a very central role in terms of making recommendations on how authorized vaccines are used, and then provinces and territories are primarily responsible for distribution and delivery of vaccines. In the beginning of the COVID-19 pandemic, Canada had very few options for domestic vaccine production, and so we therefore focused on procurement, which basically secured us the world's largest number of potential COVID vaccine doses per capita. There were several pivotal NACI recommendations. I named 3 here that had a large impact on how our vaccine program was rolled out. The first one was extended dose intervals for COVID-19 vaccines. We very early recommended vaccination in adolescents, and we also recommended interchangeability of vaccines. I will kind of wrap up with an example of Ontario, where we kind of look at vaccine rollouts. Some highlights, including what we call a hotspot strategy, where we have more of an equity focus in terms of how vaccination is rolled out. And I will finish up with some challenges, which were primarily related to doing things differently than every other country or everyone else, or at least perceived to be doing things differently, and also in terms of communication. All right. So we'll speak briefly just in terms of situating ourselves. So Canada is a country with close to 38 million population. We have a decentralized, universal, and publicly funded healthcare system. We have 10 provinces and 3 territories. I say they they pay for about 80% of the healthcare and administer the healthcare system. So in effect, we have 13 single payers that are very distinct, but similar as well in a lot of different ways. And then the federal government has kind of more this overarching role in terms of setting it and administering principles for healthcare system in Canada, assisting with the financing, so kind of paying the other 20% of healthcare to the provinces and territories, deliver some healthcare services to very specific groups like the First Nations and veterans, and providing and funding other kind of health-related functions, including public health. So COVID-19 pandemic in Canada, we had the first case travel-related on February 27 in 2020, and community transmission was established early March 2020. And about 2 weeks later, we declared a state of emergency. As I mentioned already, Canadian provinces and territories had two major different approaches in terms of how we try to mitigate the pandemic. So we had some provinces that did COVID mitigation strategies, so basically trying to maintain COVID at a manageable level. And some provinces had a near zero COVID strategy, basically aggressively dealing with any type of outbreaks and restricting travel from high COVID areas. And we started vaccination on December 14. And so in the figure to the right, you kind of see the different continents and where Canada and the province of Ontario, which is the dotted red line, lies. And as I mentioned as well, so we already have had 3 waves, and we are in the beginning of a 4th wave right now. We started very, very slowly in terms of vaccine rollout, but we are now one of the leading countries in terms of vaccine coverage, especially among our peer jurisdictions, so kind of countries that are similar to us in terms of healthcare system, economy, and other types of characteristics. So as of now, we have 72% of the entire population is vaccinated with at least 1 dose, 62% with 2 doses. So kind of how did we get there? I do need to speak a little bit about the regulatory environment. So as I mentioned, it's a shared responsibility across national, provincial, territorial, and local public health agencies. In Canada, we have Health Canada, which is similar to the FDA in the United States, who authorizes health products for use in Canada. And they're basically looking at safety and efficacy and quality. And they regulate products as well after they are authorized. Then we have the Public Health Agency of Canada, again, the equivalent would be CDC in the US, under which umbrella we have the National Advisory Committee on Immunization, or NACI. NACI makes recommendations on the use of authorized vaccines, but the Public Health Agency overall has also a role in vaccine safety, surveillance, and working with the provinces and territories. And then provinces and territories basically determine in general publicly funded vaccination programs within their jurisdictions, and they are responsible for funding, distribution, and delivery of vaccines. Again, so at the beginning, we have had basically no domestic production, so we were not able to produce our own COVID-19 vaccines. It changed a little bit more recently. We have now a new biologic manufacturing center that can produce the Novavax vaccine, supposed to be by the end of this year, early next year. We have a local company called Medicago that are currently developing COVID-19 vaccines that are in phase 3 trials. And we just this week signed an agreement with Moderna to build a manufacturing plant in Canada. So we focused on procurement, and we procured vaccines for Canada, but also to add to COVAX and provide some international support, so that we had over 400 million doses of vaccines and vaccine candidates. And so here you can see roughly what the breakdown is. Most of the vaccines that Canada has, out of the ones that are currently authorized, is Pfizer with 76 million doses. Basically, this alone would be enough to give each Canadian 2 doses. And there are also a bit of AstraZeneca, quite a bit of Moderna, quite a bit of Johnson & Johnson, and then there are other vaccines that are still in the pipeline and that are not currently authorized. And so just to get back to Pfizer, because that's where we have most of the vaccines. So we have fixed contracts and they go into 2020, all the way into 2024. including any type of adaptations of the product in terms of younger population groups or new variants. Quick overview of what NACI kind of looks like under normal circumstances and where it fits into the process. So you start on the left-hand side with vaccine innovation, research, development, which is done basically industry, academia, public health agency providing some guidance. Then if vaccine is developed, it will be authorized in Canada through Health Canada. And only after that's basically coming to the National Advisory Committee for Immunization, which provides scientific guidance. And traditionally, NACI was looking at safety, immunogenicity, and efficacy of vaccines. And then the provinces and territories would look at programmatic issues. So like whether it's cost effective, is it accepted, is it feasible to add this vaccine to the public program, and is it equitable? But since 2006, the mandate of NACI was expanded to 2016 was announced to expand the mandate to basically include those programmatic considerations into NACI guidance. With the launch of this at the end of 2019. And so then basically came COVID. And so it's still slowly but surely kind of moving into that direction. And then we have the provinces again and territories to implement vaccines and supply management by Public Services and Procurement Canada, which is federal. And then again, we have program evaluation and surveillance, which kind of feeds back into the process, for example, looking at safety to the Public Health Agency and Health Canada. Now, this long kind of step-by-step process was heavily combined really during COVID-19, where a lot of the things were kind of going on in parallel. So manufacturers could submit any type of new data that was available on a rolling basis to Health Canada for review and authorization. And at the same time, NACI would already actually look at providing scientific advice so that as soon as the vaccine is authorized, NACI would also give recommendations in terms of how the vaccine should be used and in which population groups. Initially, given the new kind of expanded role of NACI, that we also kind of now not only look at safety and efficacy, but also kind of implementation programmatic considerations. One of the very first statement of NACI was around prioritization. And so NACI's role in this is really around strategic kind of sequencing of key population groups. So if you look at the left-hand figure, it would start with all people and people residing in Canada, and then there are healthcare workers and healthcare workers that are in contact with specific risk groups. So NACI, for example, would make recommendations on what the prioritization is and where healthcare workers fall into that. But then as it gets more specific, for example, nurses in hospitals with patients of advanced age, then that becomes more operational, and that would be a role for the federal and provincial territory. And some of the considerations then also differ between the two, kind of what NACI at the federal level recommends and what is kind of more operational, where we would consider also epidemiology mostly and the vaccine characteristics as they are available, as well as ethics, equity, feasibility, and accountability. But then the programs within the province and the territories may have many other considerations as well. Just an overview. So we've basically published 16 statements in the last 8 months. So that's about 2 per month. On all kind of things around. That's only on COVID-19 vaccines. So basically every time new evidence became available or Health Canada has approved a new vaccine, then we would put out a statement. Some of the very critical statements I do want to mention. So here see on the left-hand side is the share of the people that received at least 1 dose of COVID-19 vaccine. So that's first dose. And then on the right-hand side, you have the second dose. And what you can see here is the really, really slow start in the beginning on the left-hand side. So basically, by end of February, we had mostly vaccinated older population groups. So we started with residents in long-term care, those over 80 years of age, some very high-risk groups, and healthcare workers. And we had the same strategy in that, like, kind of age-based and maintaining the interval of either 21 or 28 days for the mRNA vaccine. So we basically were holding back the second dose, and so we made a very slow progress. And in early March, we made that recommendation that it's okay to extend the dose interval between the first and second dose to up to 16 weeks. And then you can see, because we now no longer needed to hold back doses, plus we got a lot of supply, we're able to roll out that first dose really, really quickly, which was a critical moment because we were also kind of between the second and the third wave. So we kind of took into consideration really, again, more than safety and efficacy, but also kind of what is the impact on the population, how we can mitigate that third wave of COVID-19. So we figured basically it's better to vaccinate a very large proportion of the population really quickly with one dose than holding doses back and vaccinate a few people with 2 doses or half as many. And you can also see then on the right-hand side, that's why our second dose kind of proportion grows really, really slowly. So basically only in June, when we had a large proportion vaccinated with 1 dose, we were able to then go back with second doses. But because we had a large share of the population vaccinated with 1 dose, you could go back and really ramp up that coverage with the second dose. And then the other key recommendations was adolescents. So basically kids aged 12 to 17 years. We made a recommendation to vaccinate with Pfizer on May 18, and we had really high uptake, which is very exciting. And we also recommended on June 1st that the vaccines are interchangeable. So if someone got Pfizer for their first dose, they could take Moderna for their second. The few people that had gotten AstraZeneca could take either mRNA vaccine as a second dose. And that, again, kind of helped with the rollout because whichever vaccine basically was available was what people would get. Now, Ontario, in terms of what happens then in the provinces and territories. So far I talked about national recommendations. In Ontario, which is Canada's most populous province with close to 15 million population, we have our own vaccine distribution task force, which are focused mostly on distribution, but also kind of modifying a bit kind of the prioritization and providing that guidance. And this is based, they take their guidance from the NACI recommendations, but then also from the science advisory table and the modeling consensus table, which are basically tables made up of scientific experts, health system leaders who look at emerging evidence relevant to COVID-19 to inform what Ontario's policy response should be. And of course, there are other pieces of information that go into this. And so in the big scheme of things, the final kind of or current 3-phase plans, I see phase 1 mostly focused on older and high-risk population groups. Then we had phase 2, April to June, so kind of mass delivery of vaccines, rolling it out as fast as possible. And there's some kind of specifics for Ontario in there that I will get to. And then phase 3, where we are now, basically kind of everyone else. So going back to the modeling advisory and modeling consensus table recommendations, over time we had 10 different recommendations that are focused on vaccines, and I want to highlight 3 because it's really that hotspot strategy that was working, in my view, very, very well in Ontario. So what we found in January, early February. So we looked back at the whole entire first year of the pandemic. And what we find is that it's very unevenly distributed, right? So large disparities across Ontario, which you see on the left-hand side in the map. So the red areas are the ones with the highest incidence of COVID-19 and the blue with the lowest. And so kind of the red there in the middle is Toronto, and you kind of have the bigger cities. And you also have areas in southwestern Ontario on the left bottom, where there's a lot of more industry and people also working across the border with the US. And so what we then did was looking at kind of stratifying our neighborhoods by risk, and risk defined as COVID-19 deaths or hospitalizations. And then we also looked at age. And so we got this kind of chart where you can see, from the highest risk neighborhoods, which are the first decile, all the way to the right to the very low risk neighborhoods, and from the oldest 80 plus down to the youngest 16 to 39. And what was really striking is that basically the younger age groups in the low risk neighborhood, the youngest age groups in the highest risk neighborhoods had a greater risk than the oldest age groups, the over 80s in the lowest risk neighborhoods. And so I'll finish up with some after things that we did to kind of get around that. So one thing was focusing on natural occurring retirement communities. So basically figuring out in the high-risk neighborhoods, are there communities, mostly high-rises, where there are more than 50-60% of seniors living. So focusing on the older population groups living in buildings and then basically going door to door. The other thing we did was looking at high-risk neighborhoods. Again, we know that in the high-risk neighborhoods, we have a larger proportion of the population that works, that are essential workers and cannot isolate and stay home, but that also live in multi-generational families and so are at higher risk. And so we stratified that vaccine coverage was actually the lowest in the beginning in the highest risk neighborhoods, and it was the highest in the lowest risk neighborhoods. So we kind of were able to show that it would be better for everyone if we focused on those high-risk neighborhoods, because we would also reduce transmission. And so we reallocated doses of vaccine to the high-risk neighborhoods and very strictly focused on those. So finally, some challenges. So in terms of the hotspot strategy, that meant we needed to increase supply to the large urban areas because that's where most of the hotspots were. And so not everyone was kind of happy about that. In terms of delivery, it was slow in the beginning also because we focused on hospitals. So the rollout was managed by hospitals initially, but then we kind of added mass immunization clinics, pop-up clinics, pharmacies, primary care, and so on. We had some supply shortage of mRNA vaccine, and we dipped into our COVAX AstraZeneca supply, which lots of people were not happy about. And so, I think the other things that were really challenging was the extended interval in the beginning. So extending the interval got huge criticism because everyone else was doing it differently. Clinical trials said 21 to 28 days, and we said 16 weeks. So that was a problem. There was a lot of concerns around AstraZeneca vaccines and then the changing recommendations as evidence involved. So it seemed like a lot of back and forth, and communication wasn't great, which didn't make it better. And the mixed schedules are still a bit of a problem, mostly because not all countries accept the mixed schedule. So people have two different vaccines. They are not considered fully vaccinated by some countries. So we're still working on that. But so far, so good. So people stepped up. We have a volunteer group. They're called Vaccine Hunters Canada. They're actually a group of volunteers that help people to figure out where they can vaccinate it, given all the kind of different mechanism that we had. And they also posted on Twitter wherever there was vaccines available and for whom, because it's just such a big mess at some point in time. And of course, all the decisions that were super controversial, that recommendations that NACI made in terms of extended interval, in terms of interchangeability, it kind of worked out really, really well. So now it's all good. But that was a real challenge at some point in time. And so I will just leave up the key messages to reiterate, I guess, where we were. 3 waves, now in the 4th wave. Immunization programs are shared responsibility across national, provincial, territorial, and local public health agencies. National Advisory Committee of Immunization plays a very large role, and pivotal recommendations were extended dose intervals for NACI for COVID-19 vaccines, adolescents, and the interchangeability. think one of the real highlights in terms of rollout was the hotspot strategy, because that got a lot of people vaccinated really quickly, reducing transmission, so kind of benefiting everyone. And yeah, challenges, I just talked about that, mostly came because we had deviated from what was considered to be the norm and not always being great with communication. So thank you. That's it. And I think open for questions, probably.
Thank you, Dr. Sander, who has shared with us the Canada experience in the vaccine rollout. I'm now glad to invite Mr. Sai Prasad from the Bharat Biotechnology Company and president of the Developing Country Vaccine Manufacturer Network to walk us through the opportunity for developing country vaccine manufacturing capacity under COVID-19.
Good day, everybody. It's an honor and pleasure to be part of this course and presenting for the IVI in this Vaccinology course, where several thousand participants are a part of it. I'm Sai Prasad. I'm the executive director at Bharat Biotech. We are a vaccines development and a manufacturing company located in Hyderabad, India. I'm also the president of the Developing Countries Vaccine Manufacturers Network. We are a network of more than 40 companies all over the world. Next. Companies in the DCVMN are located in every region of the world. As I mentioned, more than 40 companies engaged in vaccines development, manufacturing, and supplies. Next. DCVMN, we represent more than 15 countries. We're present in all the WHO regions. We've manufacturers have produced more than 3.5 billion doses of vaccines. This is in 2019. This is across 50 distinct vaccine products. And DCVMN supply more than to 170 countries globally. And also these are pre-pandemic numbers. And today, during the pandemic, the volumes have even increased. And it's not just all of volumes, it is also high quality manufacturing. 15 developing country vaccine manufacturers have vaccines that are pre-qualified by WHO, making them eligible for procurement by UN agencies, namely UNICEF and PAHO. 78 vaccine products have attained the WHO pre-qualification, which means they can be accessible. Next. And DCVMN members are also spread out and present in all WHO regions. Recently, we did a detailed survey of our entire membership, and this has been published. You will see the references in the slides to come. As you can see, all regions of WHO, starting with the Americas, Africa, Southeast Asia, Mediterranean, Western Pacific, all are represented by our network. Next. And when we look at specific manufacturing capabilities and expertise, we start with what we call as the drug substance. In other words, we call it the active ingredient or the bulk. There are many different technology platforms for this. One is recombinant technologies for mammalian cells, cell culture, bacterial or yeast fermentation, and also recombinant technologies for non-mammalian cells. mRNA technologies, as you can see, most modern COVID vaccines are being manufactured, and also purified plasmid DNA. There are DCVMs that are manufacturing plasmid DNA technologies. And these are also evenly spread across South Asia and all the other WHO regions. Next. The next concept that we think of is drug product manufacturing facilities and capabilities. And when we think about drug product, we look at the formulation capacity. How much of a drug product can be formulated in a given day? And you can see the representation based on liters per day in different regions. And as you can see, most of the manufacturing for drug product in the developing world happens between the Western Pacific region and the Southeast Asian region, which is almost more than 80%. So this is a very important part of vaccines manufacturing, because this is where the vaccines get bottled into the final vials that you see. They are stoppered, sealed, and heavily tested before release. Next. And The next part after formulation is filling capacity. This is how many vials can be filled on a daily basis or a minute by minute basis. This also has been documented across all the different companies and also across all the different regions. As you see, it is widespread and well distributed across all the regions. But as you can imagine, we had requested as a part of the survey highly confidential information from many companies. So this information is not 100% representation because some companies may not have given certain confidential information, that can be shared publicly, although our information is anonymized. Next. So having given you an overview, what do we see as gaps in vaccine manufacturing? What are the problems that we see? One of the main problems that we see is most vaccines manufacturing is located in developing countries, specifically for global supplies, but they are located in Asia, India, Indonesia, China, Korea, etc. And there is poor geographic representation for global supplies from other regions. Why do I say that? I say that because Africa, for example, has a few companies in South Africa, in Senegal, for example, but they're mostly catering to local requirements. Latin America also has a few companies in Mexico, in Brazil, in other countries, again, mostly catering to local requirements. Eastern Europe, there are companies with historic experience and capabilities, but they are not manufacturing and supplying vaccines for the global need right now. And also Central Asian countries have some expertise, but they need to be improved even more. Next. And again, some of the more reasons that we have for gaps in vaccine manufacturing is because of lack of sustainable pricing for a healthy industry. What do I mean by that? There is a constant downward pressure on vaccines pricing with the intent of making it affordable. The heart and mind is in the right place, but this constant downward pricing is resulting in reduction in number of suppliers, market exits by existing manufacturers and suppliers. There is also a consolidation of existing supplier base with vaccines, with lots of mergers and acquisitions. And there is a general progression towards large volume manufacturers, which are manufacturing at a very, very low cost. And this, I see, is a fundamental problem that is facing our industry. And access to technology is complex and varied, but accessible. Technology today is accessible compared to 20 years ago. Technology is more accessible today. And there is another fundamental major problem for our industry, which is very, very long lead times for vaccinology and product development. If you can think about regulatory approvals and vaccine development, clinical trials, etc., it takes anywhere between 10 to 15 years. Facility development and qualification and validations, regulatory approvals also take anywhere between 5 to 7 years. And investment ticket sizes are approximately greater than $100 million for a facility or product development, for example. And regulatory approvals, you need 2 to 3 years in each country, even after the approval in the first country. For example, we are an Indian company. After we get Indian licensure, we still need 2 to 3 years of time to get the products approved in other countries outside of India, even with WHO pre-qualification. And market access and distribution scale up, it takes approximately 5 years for products to reach many, many countries post-regulatory approvals. And having put all of this, if you can think about it, it takes 10, 15 years to develop a vaccine, 5 to 7 years to qualify facilities, lots of money investment. And the return on investment almost takes 10 years post-regulatory approvals. So if you start investing money into a facility for construction and product development, you're already losing 10, 15 years. And then after you get licensure, you need another 5 to 10 years for you to get your return on investment. So it becomes a 20 to 30 year long project. So this is what is a problematic issue in vaccines. So this is why only entities that have very, very long-term thinking, deep pockets, for example, generally invest into vaccine industry. Next. The ecosystem is also very important. We need lots of different types of human capital, starting with biological sciences, chemistry, mathematics, statistics, pharmaceutics. We need, even in engineering, we need chemical engineers, mechanical engineers, electrical engineers, computer sciences. We need medical doctors, we need veterinary doctors, we need epidemiologists. So it takes a very wide group of people to be a part of this industry, to take care of product development and related activities. We also need a very good academic research environment. I mean, if you want to set up a vaccine company, you need to have good academic labs, good researchers, good technicians, good skill sets that can be leveraged by industry. Vendors and suppliers are important. You need a family of vendors that can help you build facilities, qualify facilities, have equipment ready and available, have process technologies, etc. Financing is an important part, but from what I understand from the global requirements today, financing is readily available, and both in the form of long-term debt, low-cost debt financing, and also private equity. Financing is readily available. But, you know, as I mentioned to you, the lead times are very, very long. So this is a potential concern for, entrepreneurs. Global logistics and distribution access is also very critical. You want to be located in a location where it is readily accessible to global markets, because most vaccines require cold chain, and this cold chain cannot be extended beyond a certain period of time, especially when it comes to shipping and transportation. And I have highlighted 3 concepts at the bottom of the slide, which I think are critical. You know, if you're thinking about a project that is 25 to 30 years in duration, then you need a really stable political environment. You cannot have a political system that's constantly changing. You need a very, very strong regulatory system. That means your local NRA, National Regulatory Authority, has to be well recognized as a strong NRA and not as a weak NRA. So that's very important, because WHO and PAHO and other regulators from other parts of the world rely on the strength of our local NRA to establish quality of our product. And also sustainable pricing for a healthy industry. I mentioned this earlier in an earlier slide, but I can't highlight this enough. What is happening is price points for many, many vaccines are going to a situation where either existing companies are moving out of the market, or new companies don't see an incentive to come in and manufacture those vaccines. I can give you an example of a pentavalent vaccine, which was initially maybe sold for $3 or $4 a dose. Currently, it's being sold for maybe 30 cents or 40 cents a dose. And this, even after companies have won tenders, they're unable to supply because the price points have become so low. And this is being repeated in many, many products as we speak, because product pricing is on a downward spiral for many of these products. In conclusion, what I would like to say is that vaccine manufacturing is very complex. It takes a lot of money to establish. It takes a lot of timelines also to establish, but it is not impossible. It is possible. Many companies, as I mentioned to you, almost 40 companies around the world have done it. I think more and more companies can do it. Especially, there is a lot of push now for vaccine capacities to be increased in Central Asia, in Africa, in other parts of the world, so that we are not all concentrated in a few countries. As you can see, this pandemic has brought to bear many of these divisions, because many countries, even to now, don't have all the vaccines that they need for this pandemic. So I hope I've given you a good overview of the vaccine industry and the issues plaguing the manufacturing processes and vaccinology. With that, I conclude my presentation. Thank you.
Thank you, Mr. Sai Prasad, for your presentation. Bear with us. You will be joining us after the presentation from Dr. Youngmi Ji. Last but not the least, I will be welcoming Dr. Ji from the Institute Pasteur from Korea to walk us through and share with us her thoughts around COVID-19 eradication. elimination, whether it's possible. So stay with us, Mr. Tsai Prasad. We'll come to you in a couple of minutes for the Q&A session. Thank you.
So good afternoon and good morning. I'm Young Mi-ji, CEO of Institute Pasteur Korea. It is my great pleasure to join IVI's 20th Advanced Vaccinology course today. First of all, I want to congratulate IVI for successfully hosting this course for last 20 years, and also all participants for joining this special course, especially during this COVID-19 pandemic. So let me share my slide with you. So let me start with public health emergency of international concern declared by WHO. So this declaration is based on WHO's international health regulations. And there were 6 occasions which WHO declared public health emergency. The first one was swine flu in 2009. The next one was polio in 2014, and this still continues. And Ebola in West Africa in 2014, and Zika in 2016, and again Ebola in DR Congo in 2019. The last one, COVID-19, was declared as public health emergency on January 30th and as pandemic on 11th of March last year. And as you all know, 1918 flu pandemic that transformed 20th century has a lot of similarities with current COVID-19 pandemic. So if you see the photos and newspapers from 100 years ago, that you can find a lot of similarities with current situation. So churches, schools, shows were closed, and you can see the temporary hospital was, and also mask wearing even for children was usual practice. And mask fashion 100 years ago, we also looking at the same trend with COVID-19. Importantly, death rate varied greatly across the globe, and this is exactly the situation with COVID-19. It was not just a respiratory disease. It had impact on all aspects of human life, including socioeconomic impact. So health reform created health ministry, disease surveillance, and the concept of socialized medicine. So after 100 years, what do we have now? We do have global governance to deal with emerging diseases, such as WHO international health regulations. And we have power of science, such as testing, vaccines, and therapeutics. And we do have public health measures, such as advanced contact tracing using AI and ICT. And recently, Bill Gates predicted pandemic will change the world in 7 dramatic ways. So those are listed here. Remote meeting will be normalized. Software will be greatly improved, and companies may share an office on rotation. So we have work at home in many occasions, and we will choose to live in different places and also socialize less at work and more in your community close to your home. And things would not go totally back to normal for a quite long time. And next pandemic may not be nearly as bad as this one. So if you see the genomic organization of human coronaviruses, it has exceptionally large genomic RNA of around 30 kilobase. It has the ability for very high genomic recombination. So coronaviruses are known to be the first class for their recombination frequency. So one of the priority pathogens for WHO's R&D blueprint was highly pathogenic human coronaviruses back in 2016 and 17. And let me talk about the principles of disease elimination and eradication described by Walter Dowdell in 1998 in WHO Bulletin. So he described indicators of eradicability, so availability of effective interventions and practical diagnostic tools, the essential need of humans in life cycle. And the success of any disease eradication initiative will strongly depend on the level of societal and political commitment, with a key role for World Health Assembly. And Durham workshop on the eradication of infectious disease in 1997 discussed the science of eradication and addressed 4 main questions: how the eradication to be defined, and what are the biological criteria, and what are the criteria for estimating the cost and benefit of disease eradication, and what are the societal and political criteria for eradication, and when and how should eradication programs be implemented. So elimination is defined as reduction to zero or very low defined target of new diseases in a defined geographical area as a result of deliberate efforts. So continued intervention measures are still required. So examples could be neonatal tetanus and measles. Eradication is complete and permanent worldwide. The reduction to zero new cases through deliberate efforts and intervention measures, including vaccination, are no longer needed. So one example is smallpox. Therefore, elimination and eradication programs come with huge responsibility. So there's no room for failure. So very careful and deliberate evaluation is needed before embarking on any program. So when we talk about the achievement of WHO, we talk about smallpox eradication. And this is the only disease we were able to eradicate. And next one is polio. So Global Polio Eradication Initiative was established in 1988. So among 6 WHO regions, 5 regions were able to achieve polio-free status. The last one was African region in 2020, last year. So one remaining region is the Eastern Mediterranean region with 2 polio endemic countries, namely Pakistan and Afghanistan. So out of 3 wild polio types, type 2 was eradicated in 1999, type 3 in 2015, and it was declared in 2019. So we still need to eradicate type 1 wild polio virus. So we had a very good news of wild polio eradication in African region last year in August. So you can see the certificate of wild polio free status in African region. Also in 2019, there was declaration of global eradication of type 3 wild polio virus on World Polio Day. So African region made huge investment to kick out wild polio. So you can see how much investment has been made to achieve the wild polio eradication. So 9 billion oral polio vaccine doses were provided. 220 million children were vaccinated multiple times every year. 2 million volunteer vaccinated supported polio campaigns every year. With that efforts, 1 million wild polio cases were averted. And you can also see the timeline of polio eradication in Africa. It took more than 30 years to really achieve the eradication of polio in Africa. So people are also worried that COVID-19 pandemic could be quite damaging to efforts to end other diseases such as TB, malaria, and polio. So COVID-19 will set the fight against tuberculosis back at least 5 years. And also WHO estimate malaria deaths could be double because of interruptions caused by COVID-19. And the Global Polio Eradication Initiative recommended all polio eradication campaigns be postponed until the second half of 2020 because of the COVID-19 pandemic. Unfortunately, in July last year, WHO announced that polio vaccination campaigns had resumed under strict COVID-19 prevention measures in Eastern Mediterranean region, including Pakistan and Afghanistan. And as you all know, Global Polio Eradication Initiative has concerted coordinated efforts of WHO, Rotary, US CDC, UNICEF, Gates Foundation, GAVI, and many other partners. And polio is one of the 2 public health emergency of international concern, which are currently ongoing. And Global Polio Eradication Initiative is also preparing for polio-free world, such as OPV cessation and containment of poliovirus and certification of eradication, as well as transition planning. So from the next slide, you can see how much efforts has been put to drive polio eradication. So you can see many documents produced and also numerous management and advisory structure. This needs a tremendous amount of coordination work by WHO and Global Polio Eradication Initiative. Those document polio endgame strategy and polio eradication strategy are dealing with 4 components of endgame strategy plan: eradication, integration, certification, and containment. In terms of financing from 1988 to 2020, over $18 billion were provided by over 100 donors. So there was huge investment to drive polio eradication, and it is still ongoing. So in fact, at the global level, polio is most heavily invested program with most dedicated health workers. So those polio workers are now also fighting against COVID-19 by educating communities on prevention and coordinating outbreak response and investigating cases and training health workers and tracing contacts. So what are the prerequisites for eradicating infectious diseases? We do need the safe and effective vaccines, but we also need vaccine distribution system at the global and regional level, which we don't really have. And there should be no animal or environmental reservoir. This may not be the case for COVID-19. So we need one health approach to maintain the barriers between the natural reservoirs and human society. We also need effective public health control measures such as surveillance and testing. And disease should be identifiable with practical diagnostic tools with sufficient sensitivity and specificity. But with COVID-19, we know that virus can be spread from asymptomatic or pre-symptomatic cases. So there are huge challenges for eradicating COVID-19. And there was also a poll by Nature. So they asked the 2 questions here. So how likely do you think that SARS-CoV-2 will become an endemic virus? So 89% answered very likely or likely. Next question, how likely do you think it is that SARS-CoV-2 can be eliminated from some regions? So 39% answered very likely or likely, and 52% answered unlikely or very unlikely. So more experts thought the elimination of SARS-CoV-2 can be quite difficult, even from some regions. They also asked about driving factors for COVID-19 becoming endemic. So they asked scientists to pick 3 out of 6 major factors. So 71% picked immune escape, 59% waning immunity, 45% uneven vaccine distribution, 37% vaccine hesitancy, and 29% lack of political will, 14% animal reservoir. So all of these factors will be important. Recently, there was some expert talking about achieving herd immunity will be impossible. So first expert is from UK, Professor Andy Pollard. He's head of Oxford Vaccine Group. He mentioned that herd immunity is not a possibility with Delta variant because it still infects vaccinated individuals. And the next person is Professor Oh from Korea. He mentioned even after 70% vaccination, fifth wave is inevitable in Korea. So we need a strategy for Delta variant and beyond. And he emphasized the importance of minimizing impact by protecting aged population and should open schools. In fact, Korean government might consider policy change from suppression of virus spread by 3T strategies and public health and social measures to focusing on treating severe cases after achieving 70% vaccination rates. But there are also some other experts mentioning that we should not dismiss the possibility of eradicating COVID-19 by comparing COVID-19 with smallpox and polio, with 17 technical, social, political, and economic factors favoring achieving eradication. So they analyzed the score for smallpox, polio, and COVID-19. So if you compare the score for the COVID-19 was much lower than smallpox, but little higher than polio. They also proposed the positive and negative factors for COVID-19 eradication. So positive factors could be safe, effective vaccines are available. We also have public health and social measures. And there is a huge global interest due to massive scale of health and social economic burden. As negative side, unequal vaccine rollout issue is a problem. So how to achieve high vaccination coverage at the global level is still a challenge. And we have issue of variant and rapid evolution of virus, as well as breakthrough infections and asymptomatic or pre-symptomatic infections. We also have problem of vaccine hesitancy. Will cost a lot of money to implement vaccination program and updating healthcare system. And we also have issue of animal reservoir that virus might further mutate. So in this very preliminary analysis, COVID-19 eradication seems slightly more feasible than for polio, but much less so than for smallpox. So this means that the goal of eradication would be much harder than for polio, but it is not completely impossible. They're also saying about some benefit in trying to eradicate COVID-19. So upgrading health systems to facilitate COVID-19 eradication could also have some co-benefit for controlling other diseases. Examples could be measles. So collectively, these factors might mean that expected value analysis could ultimately estimate that benefit outweigh the cost, even if the eradication may take many years and has some risk of failure. They also raised main questions. Could sustained COVID-19 eradication be technically feasible with currently available technologies? And should eradication be attempted based on its desirability in terms of benefit versus cost and risk of failure? And they also propose potential next steps to take a more sophisticated approach by giving the different categories weights, and also by making comparisons with measles, and also modeling work integrating both health and economic aspects of COVID-19 control. So I want to emphasize again what Walter Dowdle described. Eradication and elimination program comes with huge responsibility. So very careful and deliberate evaluation is required before embarking on any program. And there were some other experts proposing potential endgame scenarios. First scenario is eradication, and this might be too aspirational. And second, elimination might be temporarily possible even without achieving herd immunity through vaccination, but it will be difficult to maintain due to socioeconomic impact. So examples we can see in Australia, New Zealand, and China. Third scenario could be cohabitation. So vaccination can prevent severe diseases and interrupt chains of transmission. Rarely, reinfection and breakthrough infections can occur. So this is tolerable endemicity situation. Last scenario is conflagration, where outbreaks can occur with moderate level of endemicity. In summary, many experts think COVID-19 eradication might be difficult to achieve, but some experts think COVID-19 eradication is not impossible. There are potential scenarios, but we still need to have more information and data on vaccination effect and from close monitoring of variant. So I want to emphasize that comprehensive evaluation is required before we launch any program. Whether we aim for COVID-19 eradication or not, we do need to establish vaccination program and surveillance and laboratory network. Obviously, this needs big investment. And there is a role for WHO in terms of global and regional coordination to collect standardized surveillance data and laboratory confirmation, as well as monitoring of variant and vaccine composition. In fact, there was WHO inaugural meeting of implementation consultation group on international pathogen surveillance network in August to leverage and strengthen genomic surveillance for COVID-19 and other pathogens as global pandemic radar. So it is very obvious COVID-19 will prompt countries to reform and improve health systems for preparing against and responding to emerging diseases. An important question for us now is how our descendants of 50 or 100 years later will evaluate what we have done in the aftermath of COVID-19. With that, I want to thank you for your attention, and I would be happy to answer any questions.
Thank you, Dr. Young-Mi Ji, CEO of Institute Pasteur Korea. Now, we're at the end of the session today. We have a last live Q&A, and I'm glad that Mr. Sai Prasad from Bharat Biotech has kindly accepted to join me for this last session of the day. Dr. Sai Prasad, are you there?
Yes, I'm here. Can you hear me well? Sorry,
yes.
I got disconnected earlier.
Yeah, thank you for joining me for this very last session of the day. I have a couple of questions for you following your very nice presentation. One of the questions is related to Africa. And as we all know, and we have seen that already, that Africa is underrepresented in DCVMN. In this era of COVID-19 pandemic, with very high vaccine demand and supply challenges, as we all know now, what are the steps for any country that needs to build vaccine manufacturing capacity supported by the government? What are the preconditions to engage, to even engage in that pathway? In which reasonable timelines this can be achieved when we know that time is against us? Please share your thoughts.
Sure, will do. I think before I answer that question, I wanted to answer an earlier question about the Philippines.
Yes.
So, the way the maps are designed, they're designed to represent the countries in which our membership is located. So as far as I know, in Philippines, we don't have any members located. So Philippines is there in the map, but it's not highlighted in a bright color. So I think there was a question about that. So I just wanted to clarify that. I think the point that I was trying to make about vaccines manufacturing is that the technology is complicated. The timelines are long, the investments are heavy, and you need a very stable environment. I think if all of these issues are available, I think countries and companies can definitely think about establishing vaccine manufacturing. There is a lot of interest right now because of the pandemic. And what I would urge countries and companies to think about is not to look at it only from a pandemic perspective, because by the time you invest money and have products ready and available, it's going to be a few years down the line, and the pandemic may or may not be there at that point in time. I think there has to be a broader vision as to why we need a vaccine company in a certain country. Over.
Thank you. There's another question. Is there any correlation between local manufacturing and improved access and uptake of vaccines?
I don't see a direct correlation as long as there are no, let's say, political or geographical or financial barriers. Why do I say that? Because if you look at vaccines today, they're only made in maybe a few countries of the world, but they are being supplied to all countries of the world. But using the pandemic as an example, again, may or may not be the right, right strategy, because if you take vaccines for routine immunization, for example, in Korea, there are vaccines made in Korea, but then they're supplied to many other parts of the world. It's not just made only for Korea. Same thing with India or China or, Indonesia, for example. But for pandemic vaccines, because of the pandemic and because of the various regulatory restrictions, there are vaccines manufactured in country X, but they're not available for country Y because they're being prioritized for certain other countries. So I think this is an issue. It's not about, manufacturing vaccines in every single country. I don't know if that's even feasible.
Thank you. If I may, there's another one for those that are not aware of that. Is Bharat Biotech Covaxin part of COVAX?
Bharat, yeah, the Covaxin, we intend to be a part of COVAX. We are in the process of getting our approval from WHO for the emergency use authorization. We have submitted all the documents and data. Our phase 3 clinical trial results were available in the month of June. And then by early July, we had submitted all the data to the WHO. So when we do get the approval from WHO, we intend to be a part of COVAX.
Thank you, sir, for your contribution to the live Q&A. I think we are at the very end of the session for the first day of this Vaccinology course. I really want to thank all the presenters, speakers for the great presentation, very concise and thorough presentation. And I also want to thank all the participants for this first day of the Vaccinology course for attending this lecture and the live Q&A. And we hope to see you tomorrow then. Thank you.